I need a coffee.
Do you want a coffee?
No, I haven't.
It's a shame because they're having a thing, and they call votes at 10. This is stupid.
So this is gonna end as soon as it
Because I said, should I even bother to come? But I said, yeah, let me check in. Just and then I.
because like a lot of these people are co-sponsors of the bill. Cardenas, Craig, Husser, Schreier, Trayvon, Rousseau.
All right, you ready?
The subcommittee will come to order, and the chair recognizes himself for an opening statement. Today's markup hearing builds off the months-long work this subcommittee has done to improve patient access to care by addressing costs, Medicare coverage policies, and provider sustainability. In July, we held a first provider-focused hearing, recently held another legislative hearing, building off what we learned in July. Separately, we also held hearings on driving innovation in Medicare. Our markup today includes bipartisan legislation that is designed to highlight three key areas of focus: lowering costs of medicines for patients in Medicare Part D, improving access to innovation through policies focused on improving Medicare coverage processes, and preserving and improving access to care through policies dealing with lab and physician reimbursement issues. Many of the bills we're marking up today will come with a price tag. Some will be small, and others will be substantial. Some will even save the taxpayer and Medicare program money. In order to advance legislation through the full committee and ultimately the House and Senate, it will need to be fully offset, and we are actively working to identify bipartisan offsets and will fully offset each of these bills and is considered at the full committee. Lowering costs for Medicare Part D patients, we're turning to bills at hand. In Part D space, we have a number of policies that address high drug costs in the market-driven manner, opposed to the those are the other policies moving forward. This includes bipartisan legislation from Dr. Joyce and Mr. Peters to help drive biosimilar access and legislation for Mr. Carter to delink PBM compensation from the list price of the drug. Additionally, we have legislation to reduce the fees pharmacists pay to PBMs for drugs long after a sale is made, and to increase transparency and predictability for pharmacists with respect to the quality measures which are evaluated. Finally, there's legislation that will ensure patients aren't paying more for a drug out of pocket than what their prescription drug plan paid for the drug. This is critical in light of the work the GAO did several weeks ago to highlight the high out-of-pocket costs paid by Medicare beneficiaries for highly rebated drugs under Part D. Beyond lowering drug costs for seniors, we're also working to enhance their access to services and providers by making sure that payments to doctors can sustain the independent practice of medicine, and that the rules that determine coverage enhance, not restrict patient access to the most up-to-date, best technology our healthcare system has to offer. Fortunately, we have a number of physicians on both sides of the dais in this subcommittee who can attest to these challenges. I want to thank everyone who has shown leadership on these issues, like Dr. Bouchon, Burgess, Joyce, Dunn, and Miller Meeks, to name a few, and to say nothing of our resident pharmacist representatives Carter and Harshbarger, who have helped bring important pharmacy issues to the forefront of this committee. Among these bills considered today are H.R. 6364 from Representative Balderson that ensures healthcare providers don't have to disclose home addresses as their office address if they're delivering telehealth from their home. H.R. 1352 from Representative Hudson that will test policies on increasing access to biosimilars. H.R. 1691, which will codify the Trump-era MCIT rule and provide automated Medicare coverage for 4 years for FDA-approved breakthrough technologies. And we have and which I know is important to the ranking member and myself. And we have a number of bills, including H.R. 5389, the National Coverage Determination Transparency Act. In closing, the bills before us today represent reasonable bipartisan reforms to the Medicare program that will ensure Medicare can meet the evolving needs of beneficiaries and providers. I thank my colleagues for their hard work on these bills, and I look forward to discussion today. I yield back and recognize the ranking member for her opening statement.
Thank you, Mr. Chairman, and good morning, colleagues. Today we're marking up 21 bills. 4 of them are policies that shed light on the disruptive role that PBMs, pharmacy benefit managers, hold in our healthcare industry, including the bipartisan Protecting Patients Against PBM Abuses Act, which changes how PBMs generate revenue from being based on the list price of drugs to a flat fee for their services. I'm very pleased that our subcommittee is moving forward on that bill and others to lower drug costs for the American people by going after the middlemen who make money by taking advantage of our complex drug supply chain. PBMs have existed since the 1960s, when the U.S. spent approximately $2.7 billion on prescription drugs over a decade. They were originally hired to process prescription drug claims. as prescription drug spending has grown to more than $378 billion each year. The three PBMs, which currently control a majority of the market, made an estimated $400 billion last year alone. We're also voting on the bipartisan Ensuring Patient Access to Critical Breakthrough Products Act of 2023, which I'm leading with several members of this subcommittee. Our bill would shorten what my constituent, Dr. Josh Mackauer of the Stanford Bayer Center for Biodesign, has called the Valley of Death for medical innovators and patients, which is the time after medical innovations receive FDA approval, but before they're covered by Medicare. According to the Bayer Center, nationwide Medicare coverage for breakthrough medical technologies can take, on average, 5 to 6 years following FDA authorization. Medicare beneficiaries deserve timely access to effective and affordable and safe treatments. While I acknowledge this bill comes at a cost, innovative medical devices are worthy investments for us to make if it means changing and saving lives. I'm committed to working with the ranking member and my colleagues on our subcommittee who are concerned about the cost of this bill and protecting patient safety. I know that the ranking member asserts in the minority memo that this legislation is a giveaway to device manufacturers. I think this is a flawed argument. This bill only applies to breakthrough devices, which means they have to be a new diagnostic or a treatment for a life-threatening or debilitating disease. They must be approved by the FDA, of course. Since 2016, about 800 devices have tried to get this designation, and only 80 total have succeeded. And it's not as if Medicare doesn't eventually cover these devices. They just do it after a 5 to 6 year delay while beneficiaries are denied care or pay out-of-pocket costs. The Provider Reimbursement Stability Act shows promise, but it needs more work to comprehensively reform how Medicare pays physicians sustainably over the long term. Medicare is required by law to offset increases in payments over a certain amount with reductions in payment elsewhere. The problems this policy creates bears our attention and not really, tinkering around the edges. I'll work with colleagues to strengthen this proposal. I am disappointed that Republicans have again refused to extend funding for state health insurance programs despite this funding expiring. Programs like HICAP, which is California's state health insurance program, helps Medicare beneficiaries enroll in Medicare and access benefits that lower their out-of-pocket costs. This program works, and it works very well. Republicans have also refused to consider legislation to extend funding for other programs, including the Area Agencies on Aging, the Aging and Disability Resource Center, and the National Center for Benefits and Outreach Enrollment. Finally, we're considering two important bills, and I wish there were more, from Democratic members Sarbanes and Schreier on supplemental benefits offered by Medicare Advantage plans and diabetes self-management education support services. Physicians and Medicare beneficiaries are counting on us to be the change they desperately need, and I hope we can find a way to do that today. So thank you again, Mr. Chairman, and I yield back.
Thank you. The gentlelady yields back. The chair recognizes the chairwoman of the full committee, Chair Rodgers.
Thank you. Good morning, everyone. I'd like to start by acknowledging and thanking my colleague, Dr. Burgess, for his 2 decades of service and leadership, passion on this committee. He's led with distinction, especially on healthcare issues. Your expertise and insights have been invaluable, and I know you're going to push to the finish here in the upcoming year, but just a big thank you for your leadership. Today, this committee is plowing the hard ground on issues crucial to the American people. We will advance 21 pieces of legislation that will make a difference for millions of people. First, to lower drug costs for seniors and the Medicare program, we will consider legislation that takes a free market approach to sharpen the incentives for Medicare Part D plans and their pharmacy benefit managers. Next, we'll work to address one of the most pressing issues facing the Medicare program today, how the program covers new and innovative technology. We saw this play out with respect to Alzheimer's related treatments. We want Medicare to be able to support our loved ones' access to the best available treatment, whether that be an FDA-approved curative medicine or a cutting-edge technology. I talked at our last hearing about how central planners will ultimately fail to pick the most efficient price possible to pay healthcare providers. They will also fail us if we leave coverage decisions to them. I appreciate the bipartisan work to improve this coverage process and ensure that more seniors have greater access to care. Finally, we will take the next step in the process of addressing how Medicare pays physicians. Congress once again finds itself considering how to address Medicare payments to physicians. We have spent a lot of time this year talking about ensuring physicians can remain in private practice. A stable and predictable policy environment would give them the certainty to plan financially and make the investments needed to do so. That is my goal, to preserve patient access to independent physicians. We will consider a short-term extension of a payment policy that prevents cuts to rural physicians while also considering legislation that takes a thoughtful, serious approach to reforming the Medicare physician fee schedule. It's always been the custom of this committee to use the regular order process to finalize offsets for bills and to iron out technical assistance from federal agencies. This Congress has been no exception, and we've frequently used hearings and subcommittee markups to advance legislation while identifying areas for further refinement. While some bills being considered today still have a ways to go, I believe that they'll be ready in time for the full committee markup. I look forward to advancing today's bills and reviewing them further with the full committee. And I yield back, Mr. Chairman.
The chair yields back. The chair now recognizes the ranking member of the full committee, Mr. Pallone, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. This committee has a long history of expanding health care coverage for seniors and ensuring that the Medicare program delivers the highest quality care. I'm pleased that we are considering a number of important bills today that address the critical needs of both Medicare patients and providers, and some of the bills will extend critical programs to provide payment stability for doctors and ensure patients can receive quality care, while also lowering health care costs for Medicare beneficiaries. These bills should be advanced to the full committee today. Unfortunately, however, there are a few bills that we haven't been able to come to agreement on. I cannot support H.R. 1691 because it puts billions of dollars into the pockets of industry while raising costs on seniors. Medicare beneficiaries are already struggling to make ends meet and face high annual out-of-pocket costs in Medicare. They often live on fixed incomes and face complex medical needs. According to a recent survey by the Commonwealth Fund, 1/3 of Medicare beneficiaries said it was difficult to afford health care costs, and more than 1 in 5 beneficiaries reported delaying or skipping needed health care because of the cost, and that's unacceptable. The Congressional Budget Office has informally estimated that the cost of H.R. 1691 would be anywhere from $7 to $12 billion. Enacting this proposal would likely result in significant cuts to the Medicare program in order to offset this spending. And committee Republicans are putting forward this bill without any proposed bipartisan pay-fors. And I will continue to oppose any efforts to increase beneficiary contributions, cut Medicare benefits, or enact spending cuts to the Medicare program. I also think that cutting Medicare provider payments in order to pay for this policy is unacceptable. This legislation also ties the hands of the Centers for Medicare and Medicaid Services from being able to protect the health of Medicare beneficiaries. Over the last few decades, we've seen an incredible acceleration in the number of scientific and medical breakthroughs. CMS is charged with an important task of determining if innovative treatments and interventions covered by Medicare meet the reasonable and necessary standard for Medicare beneficiaries. This is important because the Medicare population is different from the general population, with more comorbidities and often unrepresented in clinical trials. There are reasonable discussions to be had about ways to improve the transparency and predictability of CMS's pathways to coverage for new technologies. However, I'm concerned that H.R. 1691 would undermine CMS's authority to maintain appropriate safeguards that protect Medicare beneficiaries. The bill would require automatic coverage of breakthrough devices, circumventing CMS's process for coverage and undermining the agency's regulatory pathways to coverage. It also hinders CMS's ability to collect follow-up data and real-world evidence to inform coverage determinations and ensure patient safety. While Republicans have no problems considering a bill to give billions of dollars to the device industry, they refuse to include Representative Craig's legislation to extend important programs that expand access to care and reduce out-of-pocket costs for seniors. These programs have been extended 11 times on a bipartisan basis, but expired on September 30th as my Republican colleagues continue to attack federal programs to placate the extreme elements of their party. Now, we're also considering a number of Part D policies intended to rein in the practices of pharmacy benefit managers and lower out-of-pocket costs for Medicare beneficiaries. I'm pleased the committee is working in a bipartisan way on many of these issues to increase PBM transparency, ensure better standardization of pharmacy performance metrics, and encourage greater utilization of biosimilars. I also strongly support H.R. 5386 that would eliminate cost sharing for generic drugs for low-income beneficiaries in Part D. This will deliver important savings to our lowest-income Medicare enrollees while also incentivizing generic usage. While I will continue to work with the committee Republicans to move some of these bills forward to the full committee, we still need additional agency feedback as well as CBO scoring. Some of the bills will likely bear significant costs and will require bipartisan cooperation to offset. And I also want to ensure that policies like H.R. 4881 do not inadvertently increase Part D premiums and costs. It's also critical that policies reforming the Medicare physician fee schedule and Medicare coverage determination processes do not result in increased healthcare costs for seniors through increased premiums or additional out-of-pocket costs. So I look forward to continued work to advance these bills and will meaningfully lower costs for seniors and prioritize their health and well-being. And if I could just say, I also really wanted to comment on the fact that I regret that Dr. Burgess is leaving us, not only here on the Energy and Commerce Committee, but also on the Rules Committee. It was so great to have somebody from our committee also on Rules so that when we went there, someone understood what we were doing. And we won't have him anymore for that purpose. But in any case, he'll be here for the rest of the year. So,
Will the gentleman yield?
yes, I will.
I've talked to you about this before. You are damaging my brand. You need to refer to me as one of the MAGA extreme Republicans on the Rules Committee.
Well, first of all, that wouldn't be true. But beyond that, all I'm saying is that you're smart. That's all I'm saying.
Thank you. The gentleman yields back. The opening statements have concluded for chairs, and the chair reminds members that pursuant to committee rules, all members' opening statements will be made part of the record. Are there any further opening statements? Seeing none, the chair calls up H.R. 5372 and asks the clerk to report.
H.R. 5372, a bill to amend Title 18 of the Social Security Act to facilitate mid-year formulary changes for biosimilars.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any time so ordered. Does anyone seek recognition on the bill? Dr. Joyce, what purpose seek recognition?
Chairman Guthrie, I move to strike the last word.
Someone's recognized?
Thank you, Chairman Guthrie. I would like to speak in support of legislation before us today, the Expanding Seniors Access to Lower Cost Medicines Act of 2023, which would enable greater patient access to biosimilar products by allowing mid-year changes in Medicare Part D insurance plan formularies. I would like to thank my colleague, Mr. Peters from California, for working with me on introducing this important bill. This crucial piece of legislation will expand access to biosimilar drugs and lower costs for our nation's seniors. When I speak to my seniors in my home state of Pennsylvania, the cost of prescription drugs is one of the most common concerns that I hear. This year, we are seeing the first ever biosimilars for popular drug Humira come online, which could present substantial cost savings for our seniors. Studies have estimated that the Medicare program could have saved over $2 billion if these biosimilars had been made available sooner. For patients and the Medicare program to realize these savings, there must be more access in Part D program. However, there has unfortunately been a lack of usage and volume in Medicare Part D for these products. By allowing biosimilars inclusion through mid-year formulary adjustments, this piece of legislation will drive down costs for seniors who are eligible for these medications. In fact, the cost estimates for this bill have shown significant savings for patients and for beneficiaries. This piece of legislation allows patients to seize the opportunity that will ensure health care is more affordable, treatments are more accessible, and that patients and beneficiaries are not subject to undue burden exclusions. This bill will go a long way to ensure quicker biosimilar access that will save patients and save taxpayers money. I urge my colleagues to support this common sense bipartisan legislation. Thank you, Mr. Chair, and I yield.
Gentleman yields back. Any else seeking recognition for discussion? Seeing no others, are there any bipartisan amendments to the bill? Seeing none, are there any other amendments to the bill? Seeing none, the question now occurs on forward in H.R. 5372 to the full committee. All those in favor say aye. Aye. All those opposed say no. The ayes have it, and the bill is agreed to. The chair now calls up H.R. 2880 and asks the clerk to report.
H.R. 2880, a bill to amend Title 18 of the Social Security Act to
Without
establish...
objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek recognition on the bill? Mr. Dunn? What purpose does the gentleman from Florida seek recognition?
To strike the last word.
Dr. Dunn, you're recognized.
Thank you very much, Mr. Chairman. I move to strike the last word. I rise today in support of my friend and colleague, Representative Buddy Carter's bill, which I'm proud to co-sponsor. This committee has made progress in policies that will shed light on the pharmaceutical supply chain and the many actors that participate within it. Of particular interest have been the role of pharmacy benefit managers. They manipulate the drug pricing ecosystem. I'm in full support of addressing entities that distort drug prices, such as the ability of PBMs to link their fees to the list price of a drug and their ability to extract large rebates from drug manufacturers and pharmacies. It is abundantly clear that PBMs have a financial interest in high list prices and that flat compensation fees and a move towards transparency would better incentivize the PBMs to compete on the value that they provide the patients. I fear that the consolidated PBM market will act to hide the ball in other ways if we address just this one practice. However, this bill does represent a critically important step in change in policy that will chip away at their ability to abuse their market power to distort drug prices. Another related PBM reform I hope we can address is the trend of blocking generic competition. Case studies in this space are alarming. The generic for a common drug, Gleevec, can be purchased for around $45 a month, but a Wall Street Journal investigation found through a large insurer, monthly supplies can cost $6,000 to $10,000 per month. I applaud Congressman Carter's efforts, and I encourage my colleagues to support this bill. I look forward to working on further reforms to lower drug costs for patients. And with that, Mr. Chairman, I yield back.
Gentleman yields back. Is anyone seeking recognition in the discussion of the bill? Pharmacists, okay. We have one ready to go, I believe.
Yeah.
What,
Okay.
what purpose does the gentlelady from Tennessee seek recognition? Oh, Buddy's there. I'll go to everybody. I'll go to her.
I'll go before Buddy.
You'll get to hear from two pharmacists.
Yeah.
Gentlelady from Tennessee is recognized for 5 minutes.
Okay, thank you, sir. I move to strike the last word. Mr. Chairman, I'd like to speak in support of Representative Carter's and Blunt Rochester's bill, which will implement additional sorely needed reforms to the BPM industry and Medicare prescription drug remarks. My colleague from Georgia, Mr. Carter, has been a staunch and unwavering advocate in developing and pushing forward common sense PBM reforms such as those contained in the bill. And what this does, it ends perverse incentives in our drug supply chains by delinking PBM compensation from the cost of medications. to ban patient steering and spread pricing, to increase transparency, and to address conflicts of interest. We know our system is broken in so many ways, from evidence revealing that in PBM's role setting, the prices patients must pay at the pharmacy counter, the prices paid vary wildly among brand and generic drugs. Moreover, independent community pharmacies in my district and across the country are being crushed by PBM reimbursement practices, and the costs are being passed down to consumers. I'm proud to be a co-sponsor of this important legislation, which cracks down on dishonest pricing techniques of PBMs and works to make prescription medications more affordable. And I urge my colleagues to support this bill, and I yield back.
Gentlelady yields back. Is there any recognition on the Democrat side? For purpose of the gentlelady from California seat recognition.
Strike the last
Gentlelady's
word,
recognized.
Mr. Chairman. I'll be brief. I'm so pleased that there is bipartisan support on this bill because more than 1 in 4 adults who take prescription drugs have difficulty affording their medications, particularly those with lower household incomes. I think that we're on target to pursue the PBMs. I don't think they do a thing for patients. When PBMs choose more expensive drugs for prescription drug plans, they really rake in the profits. Almost 80% of all prescription drug claims were filed by 3 PBMs, and their revenues exceeded $400 billion last year. This bill prohibits them from charging more for a drug than it reimburses pharmacies for it. I think that's pretty sensible. It also prohibits PBMs from paying pharmacies less if the PBMs don't have a financial stake in them. The Senate Finance Committee advanced similar bipartisan proposals earlier this month that build on the PBM reforms previously passed in July. So also put me on the record as being fully supportive of the other PBM bills that we're considering today to take action on the PBM industry, to take action on the PBM industry in the name of improving care for patients. So let's get this one done. I think that this will provide real bragging rights for members of this subcommittee for taking this on, and I yield back.
Gentlelady yields back. Is there anyone seeking recognition? What person, gentleman from Georgia, seek recognition?
Mr. Chairman, I am told that I'm not to say to move to strike the last word. Evidently, the resident lawyer on our committee says.
Gentleman is recognized to speak on the bill.
Thank you. Thank you, Mr. Chairman. Mr. Chairman, I ask unanimous consent to submit a letter from more than 60 organizations representing patients, providers, pharmacists, small businesses, and advocates in support of this bill.
Without objection, so ordered.
Thank you, Mr. Chairman. Mr. Chairman, I'm pleased to see my bill, H.R. 2880, the Protecting Patients Against PBM Abuses Act, is included in this markup today. This bipartisan legislation that I introduced with Representative Lisa Blunt Rochester will protect patients and pharmacies from harmful PBM practices that are making healthcare inaccessible and unaffordable for millions of Americans. First, before I begin, I'd like to put into context just how powerful PBMs have become. Just 3 PBMs control 80% of all prescriptions processed in the U.S. They own or are owned by insurers and have vertically consolidated their businesses to own everything and everyone between themselves and the patients, including doctors, pharmacies, group purchasing organizations, and more. Yet PBMs do nothing more than process claims. They're paper pushers. I like to say they bring no value to the healthcare system whatsoever. Well, now, you don't just have to take my word for it. Reports from the GAO, MedPAC, and the OIG confirm these things. Patients are being deprived of billions in discounts at the pharmacy counter. According to a recent report from the GAO, Part D beneficiaries pay more than their insurers for 79 of the 100 most highly rebated drugs under the program. And PBMs are often paying pharmacies they own more for drugs than they are paying independent pharmacies. It's time for Congress to do its duty and stop these PBMs from gaming the system and return the dollars they profit back to patients. That's why I urge this committee to support this bill, the Protecting Patients Against PBM Abuses Act. PBMs currently get compensated by charging fees calculated as a percentage of the cost of the medicine. When PBMs have misaligned incentives to favor medicines with higher list price, it can lead to higher costs for patients who face cost sharing and deductibles and insurance that is typically based on list price. This is one of the examples that Dr. Neal was giving just a second ago. The Wall Street Journal recently reported that across the selection of so-called specialty generic drugs, Cigna and CVS's prices were at least 24 times higher on average than roughly what the medicines manufacturer charge. It can also mean patients have fewer and higher cost choice when PBMs disfavor generic or lower price brand competitors. For example, the three largest PBMs continue to block more than 1,150 treatments from their formularies, including low-cost insulin alternatives. Delaying action any longer on this bill will result in increased costs for patients. You know, my patients never ask me to dispense them a medication with the highest priced medicine. Why do the PBMs think that's what's best for patients? By delinking administrative fees paid to PBMs from the price of medicines, this proposal will help to correct these misaligned incentives and bring relief to patients at the pharmacy counter. The CBO, the Congressional Budget Office, estimates that delinking in Part D would save more than $200 million in federal spending. Representative Lisa Blunt-Rochester and I are proposing this bipartisan bill that will help patients afford their medicine and protect them from harmful PBM practices. Another critical part of this bill is that it prohibits PBMs from reimbursing non-affiliated pharmacies at a rate less than they reimburse their own pharmacies. A recent MedPAC report indicated that vertically integrated PBMs in Medicare Part D may be benefiting from higher reimbursements to their own pharmacies while increasing costs to the Part D program. This bill, the Protecting Patients Against PBM Abuses Act, ends PBM's misaligned incentives that are driving up prices and costs for patients. Especially now, with inflation near 40-year highs, Congress must use all tools at its disposal to help vulnerable patients stretch the value of their dollar. Now, let me be clear. Opponents to this legislation are choosing to prioritize insurer and PBM profits over savings for patients. Patients deserve the best drugs at the lowest cost, and pharmacies deserve the right to do business without the hassle of middlemen looking to make a cheap buck. I greatly appreciate the work of this committee and so many of my colleagues to start to rein in these PBM tactics and put patients first. But we must continue to do more. That's why I urge my colleagues to support this bill, the Protecting Patients Against PBM Abuses Act. Thank you, Mr. Chairman, and I yield back.
The gentleman yields back. Does anyone seek recognition? Are there any other recognition? Are there any bipartisan amendments? Seeing none, are there any other amendments? Seeing none, the question now occurs on forwarding H.R. 2880 to the full committee. All those in favor say aye. All of those opposed say no. The ayes have it, and the bill is agreed to. We'd like to do one more bill, I think, before we break to move forward. Address one more bill. So the chair calls up H.R. 5393 and asks the clerk to report.
H.R. 5393, a bill to amend Title 18 of the Social Security Act to ensure...
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek recognition on the bill? The gentleman from Virginia, you're recognized for 5 minutes to speak on the bill.
Thank you very much, Mr. Chairman. My bill, H.R. 5393, the Transparency and Fairness for Pharmacies Act that I crafted with my friend from Georgia, Mr. Carter, will take important steps to help rein in and bring more transparency to direct and indirect remuneration, commonly known as DIR fees, and all pharmacy fees by pharmacy benefit managers, PBMs. It would require the Centers for Medicare and Medicaid Services, CMS, to create standardized quality metrics for health plans and PBMs to use when determining payments to pharmacies. PBMs often charge fees that are subjective to pharmacies based on how well the pharmacy performs. These performance measures are known as quality measures, but these quality measures are not transparent and are based on subjective standards, sometimes known only to the PBM. Pharmacies are forced to pay these fees in order to stay within health plan networks. These fees can be applied retroactively, sometimes months after the medicine has been dispensed. PBM pharmacy measures that are unfairly applied against all pharmacies have contributed to over 107,000%, have contributed to over a 107,000% growth in pharmacy DIR fees, according to CMS, undercutting pharmacy reimbursement and increasing patient drug costs. Currently, PBMs use quality measures that are often unknown and unpredictable, inconsistent, and beyond a pharmacy's control, which then figures significantly into the DIR fees pharmacies are forced to pay. Over time, PBMs have been allowed to operate virtually unchecked, leading to abuse of pharmacy performance evaluations and lack of transparency in pharmacy payments. My bill seeks to end these practices. This is one of the main issues I hear about when traveling throughout my district and the importance to help correct this opaque system. One small pharmacy in my district in Saltville, Virginia, says if they have to continue to dispense every medication for patients as they did in 2023, they have a conservative estimate that they will pay up to $80,000. This is a small town. $80,000 in DIR fees during the first 3 months of 2024. The amount this pharmacy must pay in DIR fees is more than they make, and they are worried they will have to close their doors if the issue is not addressed. These DIR fees have led to pharmacy closures all across the country and in my district as well. It is not just the rural community pharmacists that are hurting from this. Everything from independent to retail to specialty pharmacies. This is one small step to bring more transparency and certainty to pharmacists when dispensing drugs, but lots of work is left to be done. I am encouraged to see that CMS will be implementing a new Part D rule targeted at pharmacies in January of next year. This rule will require DIR fees to be assessed at the point of sale and hope to mitigate these outrageous DIR retroactive clawbacks. While I think that rule is well-intentioned, I am interested to see how it will play out and if it will truly stop these clawbacks while also monitoring the effect it has on patient premiums. We also need to do more to protect our pharmacies, and I would like to continue working with the committee on this effort to ensure PBMs can no longer undercut pharmacy reimbursement below the cost to acquire and dispense drugs, forcing the pharmacy out of network and many times out of business. I urge passage of this bill and hope that all of us can continue to work together to provide comprehensive reforms needed to protect patient access to pharmacies in our communities. And I yield back, Mr. Chairman.
Gentleman yields back. Anyone seeking recognition to speak on the bill? Seeing none of the Democrat, anybody? The gentleman from Georgia is recognized for 5 minutes to speak on the bill.
Thank you, Mr. Chairman. Mr. Chairman, this important legislation that Representative Griffin and I have introduced would finally require CMS to establish standardized and relevant pharmacy quality measures addressing one-way PBMs have manipulated pharmacy DIR clawbacks and undercut pharmacy payments. I hope that all of us can continue to work together to provide the comprehensive pharmacy reimbursement reforms needed to protect patient access to pharmacies in their communities. Today, many community and specialty pharmacies are being reimbursed underwater, which is intentional to keep them out of network, limiting a patient's choice of pharmacy. This is simply wrong. There's bipartisan support for addressing this serious problem, and I was pleased to hear our counterparts on the Senate Finance Committee take action to address this concern in the PBM reform legislation they advanced last week. As you all know, pharmacists are one of the most accessible healthcare professionals in America. 95% of all Americans live within 5 miles of a pharmacy. Pharmacists are also among the most highly trusted healthcare professionals. People count on our training and expertise to stay healthy and informed. Yet PBMs are putting pharmacies out of business and removing patients' access to care. We know that 4% of all independent retail pharmacies go out of business every year. That's why I'm proud to champion this bill, which will support patient access to pharmacies, and I urge my colleagues to do the same thing. Thank you, Mr. Chairman, and I yield back.
The gentleman yields back. Does anyone else seek recognition on the bill? Are there any bipartisan amendments? Seeing none. Are there any other amendments? Seeing none. The question now occurs on forward in H.R. 5393 to the full committee. All those in favor say aye. Aye. All opposed, no. The ayes have it. The subcommittee will stand in recess and will reconvene 10 minutes after the last vote is called, not when the last vote closes. When the last vote is called. The subcommittee is adjourned. Recess is recess. Subcommittee will come to order. The chair calls up House Resolution 5, HR 5385, and asks the clerk to report.
H.R. 5385, a bill to amend Title 18 of the Social Security Act to establish pharmacy benefit.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point, so ordered. Does anyone seek recognition on the bill? Seeing none. I know we have, here we go. So our purpose is the gentlelady from Tennessee seek recognition.
Mr.
You're recognized
Chairman?
for 5 minutes to speak on the bill.
Thank you. I'll make it brief. I want to thank Chairs Guthrie and Rodgers and Ranking Members Eshoo and Pallone and the subcommittee for taking up legislation I introduced with Representative Landsman, H.R. 5385, Medicare PBM Accountability Act. This bipartisan legislation builds on the Energy and Commerce's Committee's commendable bipartisan work to rein in pharmacy benefit manager abuses, make their operations more transparent, and make these entities more accountable. H.R. 5385 will help lower the cost of prescription drugs for seniors covered by Medicare Part D and Medicare Advantage plans. Current federal law does not require PBMs to report to Medicare prescription drug plan sponsors the cost savings they've secured. Without this transparency, PBMs are able to withhold the true cost of prescription drugs, potentially keeping the cost savings as profits instead of passing them on to seniors. This legislation will require PBMs to report the cost savings they've secured, empowering prescription drug plan sponsors to be in a stronger position to ensure that cost savings actually benefit seniors through lower prices on prescription drugs as intended. This bill mirrors bipartisan legislation that passed out of the Senate Finance Committee in July 23 as a part of a larger legislative healthcare package. To lower costs and improve seniors' quality of life, we have to hold the PBMs more accountable. With bipartisan support, this legislation will save seniors real money, and I urge my colleagues to support this bill and work with us and our colleagues in the Senate to enact this important measure into law. With that, I yield back.
Gentlelady yields back. Anyone seeking recognition for a purpose of speaking on the bill? Seeing none on the Democratic side. Gentleman from Georgia, you're recognized for 5 minutes to speak on the bill.
Thank you, Mr. Chairman. Mr. Chairman, I'd like to speak in support of the Medicare PBM Accountability Act, which was introduced by Representative Harshbarger and Representative Landsman. Several months ago, this committee took crucial steps toward improving healthcare access and affordability for Americans. In advancing the Lower Cost, More Transparency Act, we demonstrated the bipartisan momentum needed to move good policy, including PBM reform. Today, we're taking another crucial step to strengthen our federal health care programs while increasing transparency and improving health care access. For 2 decades, Medicare Part D has served as a lifeline for countless seniors and Americans with disabilities, ensuring coverage for a wide range of safe and effective medications. However, this committee has witnessed market dynamic shifts caused by misaligned incentives. Consolidation has constrained competition, and patients are paying more at the pharmacy counter than ever before. Over the past 5 years, out-of-pocket costs for Medicare seniors has risen at nearly 3 times the rate for commercially insured consumers. That is unacceptable. That is why I applaud Health Subcommittee Chair Guthrie, Chair Rodgers, and this committee for continuing to increase transparency on some of the most egregious and deceptive practices of PBMs. The Medicare PBM Accountability Act will require PBMs to disclose behind-the-scenes practices that drive up prices and cost and would empower Medicare to negotiate lower prices. For far too long, PBMs have been playing pricing games in Medicare Part D that raise out-of-pocket costs and limit access to the community pharmacy of choice for seniors while threatening the viability of small businesses' pharmacies. These anti-competitive practices have gotten worse as PBMs have vertically integrated. That's why I applaud Representative Harshbarger for introducing this bill, which will shine a light on PBM tactics that are fostering anti-competitive practices and conflicts of interest in Medicare. I urge my colleagues to support this bill. Thank you, Mr. Chairman, and I yield back.
Thank you. Thank you. The gentleman yields back. Ms. Dingle, you're recognized for 5 minutes to speak on the bill.
Thank you, Mr. Chairman. I move to strike the last word and speak in support of the bill. Thank you. Like many of my colleagues, I remain deeply concerned about the role pharmacy benefit managers play in complicating seniors' access to necessary prescriptions. For far too long, and it's not just seniors, by the way, for far too long, PBMs have been allowed to operate virtually unchecked, leading to higher costs of prescription drugs and restricted access to a patient's choice of pharmacies and medicines that are right for them. And it really needs to stop. I support the Medicare PMB Accountability Act that's being led by my colleagues, Representatives Landsman and Harshberger, and I thank them for their leadership in addressing these predatory practices. As a Congress, we must be doing more to put a stop to the PBM's abusive tactics that are harming both patients and pharmacies, and I hope we can continue to work together to provide comprehensive PBM reforms that will protect patient access to pharmacies. To that end, I have also introduced H.R. 5400, the No PBMs Act, alongside my colleague, Representative Carter. The No PBMs Act will ensure pharmacies are fully protected from abusive contract terms that are offered on a take-it-or-leave-it basis, including below-cost reimbursement. The reality is, pharmacies all over the country are struggling to keep their doors open while PBMs are padding their pockets. I hope my colleagues will work with Mr. Carter and I to advance the reforms included in the No PBMs Act to ensure all segments of pharmacies are protected so that patients can continue to access medicines when they choose. We must stop allowing PBMs to exploit the system, drive up their own profits, and the reality is hurt patients. It's flat out wrong. Thank you, Mr. Chairman, and I yield back.
The gentlelady yields back. Anyone else that can to speak on the bill? Seeing none. Are there any bipartisan amendments?
Mr.
Seeing
Chairman.
none. Is there an amendment?
Yeah.
Are there any other amendments? The lady from Tennessee is recognized.
Thank you, Mr. Chairman. I have an amendment at the desk. It's Harshberger TN 032.
The clerk will report the amendment.
Amendment to H.R. 5385, offered by Ms. Harshbarger.
Without objection, the reading of the amendment is dispensed with, and the gentlelady is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman. I'm offering this amendment to ensure cancer patients get timely access to life-saving treatments. I've heard from Tennessee oncologists as well as others around the country who said this is a major problem impacting patients across the country. In 2021, the Centers for Medicare and Medicaid Services published a frequently asked questions document that impedes Medicare beneficiaries with cancer from getting their oral chemotherapy and related oral chemotherapy therapies and supportive care drugs from their treating providers. CMS's FAQ indicates that a practice dispensing drugs from a dispensing facility or associated pharmacy, such as an oncology or urology practice treating cancer patients, violates the federal Stark Law prohibition on self-referral if it delivers by mail or otherwise these critical drugs to their patients, especially when the patient is too sick or unable to get transportation. It requires the patient to pick up their own drugs from the practice, even prohibiting a family member or caregiver from picking up the patient's drugs. This is a terrible burden that forces Medicare seniors and disabled beneficiaries to have to travel themselves back to the clinic to pick up life-saving medications. This is particularly problematic in rural areas like Tennessee, where they're forced to travel great distances at their own expense. In Tennessee, we already have seen examples of beneficiaries who simply aren't coming back in to pick their drugs up, impacting the overall outcome and care and effectiveness of the treatment. In some cases, it results in failed treatments. In addition to patient harm, CMS is gifting pharmacy benefit managers and their associated mail-order pharmacies with the power to eliminate medical practices dispensing oral cancer drugs and other serious disease medications from the PBM networks. We already know that they have a vested financial interest in dispensing these medications from their own affiliated mail-order pharmacies and have been actively trolling for patients. Unfortunately, PBM mail-order pharmacies have all types of problems, including degrading drugs in the heat, delaying deliveries, and even denying drugs. And I just heard of one case where the PBM mail-order pharmacy was going to charge a patient $700 for a drug that the oncology practice dispenses for $70. Lastly, I'll point out that medical practices have safely engaged in delivering drugs to their patients during the last 10 years, especially as oral cancer drugs account for close to 40% of cancer treatment. So it was a shock to practices when CMS informed them in the FAQ that they were operating under a waiver of Stark during the public health emergency. However, once the PHE concluded, the waiver expired, and now the policy in place is having a profound and adverse consequence for Medicare cancer patients. My amendment is simple. It repeals the CMS FAQ and allows physician practices to safely deliver medications to their patients. My bill on which this amendment is based is H.R. 5526, the Seniors Access to Critical Medications Act. It has broad bipartisan support with 36 members on the bill, and especially from this committee. Cancer patients are being impacted every day from this decision, and lives have been put in jeopardy. Mr. Chair, I'd love your support to find a path forward for this, including this legislation. This can't wait because cancer patients shouldn't have to jump through hoops to get their potentially life-saving medications. And thank you, Mr. Chair. If no other member wants to speak on my amendment, I'll withdraw the amendment and yield back. If there's somebody who wants to speak on it, I'll be glad to hear from them.
Thank you. I believe there are people that do want to speak on the amendment. Anyone from the Democrat side want to speak on the amendment? Seeing none, the chair recognizes the chair of the full committee, Chair Rodgers, for 5 minutes.
Mr. Chairman, I move to strike the last word. I agree with my colleague, Ms. Hirschberger, and I'm glad that she's bringing this issue up. I'm in full agreement. Our oncology and other specialty physicians need to be able to get the medicine to their patients. If a chronically ill patient needs that medicine delivered or to have a loved one to pick it up, that option should be available to them. But the healthcare system is complicated, and we must protect patients from actors who would exploit vulnerabilities in the system to profit at their expense. The healthcare system is also consolidated and becoming more so each day. This committee is actively trying to address such consolidation. It's becoming ever likelier that the physician who provides a patient's care is owned by the insurance company that also owns a PBM and pharmacy. We've heard countless stories about how PBM self-referral to their pharmacies has created patient access issues. One important question we need to answer: if we relax self-referral rules across the board, could PBMs hold those doctors hostage and require them to use their pharmacy when a Medicare patient might have another, better option? This is an issue we can and will work through as we try to advance this bill. I commit to all of my colleagues to do the work necessary to get this legislation in place that can receive broad bipartisan support. And in the meantime, we will continue pressing CMS to find immediate solutions for cancer patients struggling today. I yield back.
Gentlelady yields back. Anyone else seeking recognition to speak on the amendment? Mr. Carter from Georgia is recognized for 5 minutes to speak on the amendment.
Thank you, Mr. Chairman. Mr. Chairman, as a pharmacist, I know firsthand the importance of cancer patients getting their drugs in a timely manner without any obstacles. Oncology practices should be able to deliver the drugs they dispense or have a family member pick up the drugs for them. CMS suggesting that patients should rely on PBM mail service to get their drugs is a non-starter because there will be delays and denials. We need to pass this simple solution that's in H.R. 5526, the Seniors Access to Critical Medications Act, for the sake of Medicare seniors and those disabled. However, I understand that the bill is going to be pulled today, but I would like to work with the committee to ensure that it is ready for consideration at a future markup. Thank you, Mr. Chairman, and I yield back.
Thank you. The gentleman yields back. The chair recognizes Dr. Dunn from Florida for 5 minutes to speak on the amendment.
Thank you, Mr. Chair. I move to strike the last word. I would like to speak in support of Congressman Harshberger's amendment. I've heard from oncologists in my district and across Florida that CMS is putting up barriers to cancer patients getting their drugs delivered to them by their oncology practices, or even worse, stopping family members and caretakers from picking up the drugs. In fact, I heard from a patient who was being treated for colon cancer with capecitabine, and the patient was able to get their first prescription through the practice in-office dispensing. However, instead of being able to get her medication mailed to her, she had to drive 6 hours round trip to pick it up next time because of the CMS FAQ. This is a very serious problem. It's even more concerning in rural areas like the ones in my district. Luckily, there is a simple solution, and that is the bipartisan bill, H.R. 5385, and we need to get this solution into law right away for cancer patients who depend on us. Thank you, Mr. Chairman, and I yield back.
The gentleman yields back. Seeing no further discussion, the gentlelady has withdrawn her amendment. So the amendment is withdrawn. So the question now occurs on forwarding H.R. 5385 to the full committee. All those in favor say aye.
Aye.
All opposed say no. The ayes have it, and the bill is agreed to. The chair calls up H.R. 5386 and asks the clerk to report.
H.R. 5386, a bill to amend Title 18.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. Does anyone seek recognition on the bill? What purpose is the gentleman from Florida seek recognition?
To speak on the bill.
Recognized for 5 minutes.
Thank you. I want to thank the chair and the ranking member for moving forward with the bill. I co-lead with Representative McGarvey, the Cutting Copays Act. This bill will ensure that the lowest income and most disadvantaged of our seniors who are on Medicare do not experience any additional barriers to getting their prescription drugs, all while encouraging greater uptake in generics. Our bill, H.R. 5386, will provide zero cost-sharing requirements for Medicare beneficiaries who are enrolled in the low-income subsidy program under the Medicare Part D. Under this legislation, LIS enrollees would pay zero copays for generic drugs and only a few dollar copays for other brand-name prescription drugs. This is common-sense legislation and can potentially help save taxpayer dollars by ensuring LIS Medicare beneficiaries are incentivized to use cheaper but just as effective, that's what I want to emphasize, just as effective generic drugs compared to their more expensive brand name alternatives. And while I appreciate and fully support the intent of the bill as currently written, I'm interested in further clarifying provisions in the bill to ensure these incentives are as strong as possible and save the Medicare program money by allowing plans to provide a tiered approach with modest copays for non-preferred drugs or off-formulary drugs. I believe this will give an added incentive for patients to choose the cheaper, generic alternatives, and I'm hopeful that the committee will work with me to come to an agreement on language to ensure that happens to fully offset the bill or even reduce the deficit. So with that, I will yield back, but I'll urge my colleagues to support the Cutting Copays Act. And again, I yield back, Mr.
Gentleman
Chairman.
yields
Thank you.
back. Is there any further discussion on the bill? Seeing none, are there any bipartisan amendments to the bill? Seeing none, are there any other amendments to the bill? Seeing none, the question now occurs on forward in H.R. 5386 to the full committee. All those in favor shall say aye. Aye. Those opposed, no. The ayes have it. The bill is agreed to. The chair calls up H.R. 4881 and asks the clerk to report.
H.R. 4881, a bill to amend Title 18 of the Social Security Act to limit
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? Seeing none, are there any bipartisan amendments to the bill? Are there any partisan amendments to the bill? Seeing none. The question now occurs on forward in H.R. 4881 to the full committee. All those in favor shall say aye. Aye. All opposed, no. The ayes have it. The bill is agreed to. The chair calls up H.R. 5389 and asks the clerk to report.
H.R. 5389, a bill to amend Title 18 of the Social Security Act to ensure transparency.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? Seeing none, is it bipartisan? Oh, this, okay. I was going to call up the amendment. Okay, you seek recognition on the bill? The gentleman from New Jersey is recognized for 5 minutes to speak on the bill.
Thank you, Mr. Chairman. I just wanted to say that I support efforts to improve transparency of CMS's pathways to coverage for new technologies and treatments of the Medicare program. And I also appreciate my Republican colleagues' willingness to make changes to H.R. 5389 so we don't hinder CMS's ability to prioritize the health and safety of Medicare beneficiaries. And this bill would improve the national coverage determination process with new transparency requirements. It would require CMS to review NCD applications for completeness and would clarify the timeline for CMS to take action. And as the bill moves forward through the committee process, I believe it's critical that we include implementation funding in order for the agency to be able to fulfill the new requirements included in the bill. And while I look forward to continuing to work with our Republican colleagues to move the bill forward to full committee, we'll also need additional technical assistance as well as Congressional Budget Office feedback. It's important that the bill does not result in increased health care costs for seniors through increased premiums or additional out-of-pocket costs. So I look forward to working with our Republican colleagues to move the policy forward, and I thank you and Ms. Eshu.
Thank you. The gentleman yields back. Is there any other discussion on the bill? There is a bipartisan amendment, at least one. I have one at the desk. I ask the clerk to report. I have an amendment at the desk and ask the clerk to report the amendment.
Amendment in the nature of a substitute to H.R. 5389, offered by Mr. Guthrie.
Without objection, the reading of the amendment is dispensed with, and I am recognize myself for 5 minutes to support the amendment. I move, this legislation would streamline the process in which the Centers for Medicare and Medicaid Services must follow whenever the agency is making a coverage decision. The current process for making these critical decisions is marked by lengthy delays and lacks transparency about the time in which it takes to make decisions. According to a recent report from 2014 to 2022, the average duration of the national coverage determination request is 483 days. For phases 1 and 2, which is when CMS acknowledges requests and initiates the evidence review, it took the agency 228 days on average to complete these two simple steps. The only people who suffer because of this unpredictable and lengthy process are seniors who need an FDA-approved therapy to treat potentially life-threatening disease. My legislation would fix this process by requiring CMS to respond within a certain time about the completeness of a national coverage determination application and bring more transparency to the process. I urge my colleagues to support this legislation, and I yield back. Are there any discussion on the amendment? Are there any other bipartisan amendments? Any other amendments to be discussed? Well, I need to do adoption of the amendment, I'm sorry. If there's no further discussion on the amendment that I brought forward, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All opposed, nay. The ayes have it, and the amendment is agreed to. Seeing no further amendments or further discussion, the question now occurs on forwarding H.R. 5389 as amended to the full committee. All those in favor shall say aye. Aye. All those opposed, no. The ayes have it. The bill is agreed to. The chair calls up H.R. 133 and asks the clerk to report.
H.R. 133, a bill to amend Title 18 of the Social Security Act.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? The lady from California is recognized for 5 minutes on the bill.
Mr. Chair, I have an amendment in the nature of a substitute at the desk.
See, there's no further discussion on the bill. There is bipartisan amendment at the desk, and I ask the clerk to report.
Amendment in the nature of a substitute to H.R. 133, offered by Ms. Barragan of California.
Without objection, the reading of the amendment is dispensed with, and the gentlelady is recognized for 5 minutes in support of her amendment.
Thank you, Mr. Chair. I would like to offer this amendment in the nature of a substitute to H.R. 133, the Merit Act, in order to clarify that the bill only applies to future coverage determinations under Medicare. As a co-lead of the Merit Act with Representative Buchanan, I thank him for his leadership on this important bill. One barrier patients currently face in accessing FDA-approved Alzheimer's treatments is a broad national coverage determination by the Centers for Medicare and Medicaid Services, or CMS, which effectively denied Medicare coverage to all monoclonal antibodies directed against amyloid for the treatment of Alzheimer's disease. This decision by CMS to deny coverage for an entire class of drugs was devastating for Alzheimer's patients who want their loved ones to have access to medication that can slow the progression of the disease. The Merit Act would address this issue by requiring CMS to evaluate treatments individually and based on their own merits rather than as a broad class of drugs. And I support this. However, I want to take this opportunity to say that as we're considering the Merit Act, I am disappointed that my bipartisan bill, the Access to Innovative Treatments Act that I led with my colleague Representative Joyce, was not included in today's markup. The Access to Innovative Treatments Act accomplishes the same goal as the Merit Act, but includes a required timeline that CMS must follow to reconsider drugs for Medicare coverage when enough data is collected on the drug's effectiveness. This is important because despite new data that demonstrated the clinical effectiveness of Alzheimer's disease treatments, CMS denied requests from Congress members and stakeholders to reconsider its coverage decision. However, again, I support the Merit Act. I think this is a critical first step to improve CMS's approach to future Medicare coverage decisions. I look forward to continuing to work with my colleagues on both sides of the aisle to build on this step. And today I'm pleased to support the act, and I urge my colleagues to vote yes on the Ains and the underlying bill. I yield back.
Thank you. The gentlelady yields back. Is there any further discussion on the amendment? Seeing no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All those opposed, nay. The ayes have it, and the amendment is agreed to. Are there any further amendments to the bill? Is there any further discussion on the bill? Seeing none, the question now occurs on forward in H.R. 133 as amended to the full committee. All those in favor shall say aye. Aye. All those opposed, no. The ayes have it, and the bill is agreed to. Next one up, 5396. Here we go. Okay. The chair calls up H.R. 5396 and asks the clerk to report.
H.R. 5396, a bill to amend Title 18 of the Social Security Act to prohibit Medicare local coverage determinations.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek to speak recognition on the bill? The gentleman from Indiana is recognized for 5 minutes to speak on the bill.
Thank you, Mr. Chairman, for allowing me to speak in favor of this legislation. My top priority as I work on any legislation is patient access to quality health care. I fight for what I think is in the patient's best interest. There are some patient-centered bills that we're not considering today that I'd love to be able to consider at a later date, including the Treat and Reduce Obesity Act and the FIND Act. But I am very grateful that H.R. 5396, the Coverage Determination Clarity Act, has been included in today's markup. This bill is critically important to Medicare patients across the country. It clarifies that the Secretary of HHS has authority to review local coverage determinations to ensure they are appropriate and establishes a regular review process moving forward. Enacting this bill will prevent local coverage determinations from being used to improperly restrict patient access to care. This is particularly important when it comes to accessing new, innovative solutions that Medicare administrative contractors don't know how to handle. I appreciate the committee's attention to this issue and urge all of my colleagues to support the bill. I yield back.
Gentleman yields back. Is there any discussion on the bill? Seeing none, are there any bipartisan amendments to the bill? Seeing none, are there any other amendments to the bill? Seeing none, the question now occurs on forwarding H.R. 4396 to the full committee. All those in favor shall say aye. Aye. All those opposed, no. The ayes have it, and the bill is agreed to. The chair calls up H.R. 5371 and asks the clerk to report.
H.R. 5371, a bill to amend Title 18 of the Social Security Act to clarify payment rules.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? Dr. Joyce from Pennsylvania, recognized for 5 minutes to speak on the bill.
Thank you, Chairman Guthrie. I would like to offer my support for a significant piece of legislation before the subcommittee today, H.R. 5371, Choices for Increased Mobility Act of 2023, which clarifies payment rules for manual wheelchairs under Medicare Part B. This bill will give individuals the opportunity to exercise their own choice when it comes to their medical equipment. The key word in this legislation is, in fact, choice. This legislation allows Medicare beneficiaries the opportunity to decide whether a titanium or carbon wheelchair is right for them. And if it is, then the patients with Medicare Part B have the ability to pay out of pocket for a wheelchair upgrade, again, if they so choose. Let's put this into context. These are not my words, but those of Dr. Ross Zaffanti from the Department of Physical Medicine and Rehabilitation at Harvard Medical School. Dr. Zaffanti says, until late 2016, Medicare beneficiaries relied on longstanding CMS guidance as well as explicit congressionally granted statutory authority for Medicare beneficiaries to have a right to upgraded items, to purchase titanium material upgrades to their complex rehab manual wheelchairs. In December 2016, the DME Medicare Administrative Contractor issued a joint publication reversing this policy, no longer allowing Medicare beneficiaries access to titanium wheelchairs. Since this joint publication, commercial plans which offer mirror CMS coverage policies also deny these upgrades, causing even more widespread access issues. This subcommittee should be encouraging Medicare beneficiaries to take full advantage of their health care plan, and more important, giving them a say in the choices that will directly impact their lives. This bipartisan legislation will remove that barrier, since 2016 has impeded access to lightweight, durable medical equipment for individuals who live day-to-day with mobility impairments. Mr. Chairman, I would like to ask unanimous consent to enter into the record 4 letters of support for this legislation. One from Dr. Zaffanti of Harvard Med and president of the Spalding Rehabilitation Network, one from the United Spinal Association, another from the ITEM Coalition, and one more coalition letter on behalf of the American Association of Home Care and the National Coalition for Assistive and Rehab Technology. I would like to offer my commitment to work with both majority and minority members of the committee prior to full committee markup to make any necessary technical changes to this bill to make sure that we get this to a place where we can all support this bill. I urge support of this important legislation, and I thank you, Mr. Chair, for bringing this forward today, and I yield.
Objection so ordered on the unanimous consent request. Or does anyone seek recognition on the bill? The gentleman from New Jersey recognized for 5 minutes on the bill.
Thank you, Mr. Chairman. I move to strike the last word. Thank you. Democrats are committed to lowering health care costs for all seniors and expanding coverage to high-quality care, and I'm concerned that H.R. 5371 would help only wealthy Americans pay for additional upgrades for wheelchairs. The bill would carve out titanium and carbon fiber upgrades from Medicare's current coverage of manual wheelchairs and would require seniors to pay out of pocket for these upgrades. I'm concerned that the bill would allow industry to balance bill seniors and only helps higher income seniors who can afford to pay out of pocket for these additional upgrades beyond what is covered under the Medicare program. The universality of the Medicare program and the fact that all beneficiaries have access to the same benefits to the greatest extent possible is an important principle. And so efforts to tier the program or otherwise make certain benefits only available to the wealthy is concerning. I'm also concerned that technical assistance provided by CMS has not yet been incorporated, and I'm not entirely clear what the legislative language accomplishes. In fact, in their technical assistance feedback, the agency noted that the bill as drafted would, and I quote, create confusion about coverage and payment requirements, unquote. I believe there are a number of outstanding issues with the bill. We also do not have Congressional Budget Office scoring, and although my Republican colleagues claim that this bill will be budget neutral, it does not appear to be the case. The bill could raise costs and result in increased out-of-pocket costs for beneficiaries, and I can't support the bill today as it is not ready for prime time, and I don't believe it's the right step for the Medicare program. So with that, I yield back, Mr. Chair.
The gentleman yields back. Anyone else seeking recognition on the bill? Are there any bipartisan amendments to the bill? Seeing none, are there any other amendments to the bill? Seeing none. The question now occurs on forwarding H.R. 5371 to the full committee. All those in favor shall say aye. Aye. Those opposed, no. The ayes have it, and the bill is agreed to. We're now, because of a little fluidity in our schedules, we're going to move to HR 555. 5555. The chair calls up HR 5555 and asks the clerk to report.
HR 5555, a bill to direct the Secretary of Health and Human Services to provide for certain adjustments to Medicare payment for items of
Without
durable.
objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek recognition on the bill? So I'll first the gentlelady from Iowa is recognized to speak on the bill for 5 minutes.
Thank you, Mr. Chairman. I'd like to speak in support of my bill, H.R. 5555, the Durable Medical Equipment Point of Service Relief Act, or DME POS Relief Act, and I'm grateful for the committee's consideration of this critical bipartisan legislation. Over 66 million Medicare beneficiaries receive services under the DME POS benefit. The benefit allows patients to receive medically needed treatments such as oxygen, wheelchairs, and medical supplies in the comforts of their home, keeping them out of expensive inpatient settings such as hospitals and nursing facilities. Due to the implementation of the DME POS competitive bidding program, which applied pricing derived from highly populated competitive bidding areas to all areas of the country, there has been a significant decrease in payment rates, which caused a significant number of DME POS location closures, especially in rural districts. Just this last year, about 11% of DME POS locations closed, further diminishing beneficiary access to DME POS suppliers. The loss ultimately leads to far less patient access and choice. The bid program was put on hold in 2018 due to the need for an update to the bidding process, and it was put on hold again in 2020 due to no additional savings. In all, the bid program has been on hold for the last 5 years, resulting in DME POS payments continuing to be based on rates from the flawed bidding program. My legislation, H.R. 5555, which I'm proud to be leading with Congressman Tonko, with the support of Congresswoman Trahan, would provide much-needed rate relief in former bid areas and non-rural areas, which will help protect patient access to cost-effective home-based care. According to the Kaiser Family Foundation, among Medicare beneficiaries in traditional Medicare, most, 86%, had some type of additional coverage in 2020, either through Medigap, 36%, employer coverage, 31%, Medicaid, 17%, or another source, 1%. Without relief to DME POS competitive bidding and non-competitive bidding areas, Medicare beneficiaries may lose access to the medical equipment they need, forcing them to go to an emergency room or a long-term care facility. This would increase cost of the Medicare program as well as the beneficiary. Thank you, Mr. Chairman. I yield back the balance of my time.
Will the gentlelady yield?
Yes.
Gentlelady yields to.
Yeah, I just wanted to speak in support of what you're doing. You'll extend for 1 year the expiring narrow Medicare reimbursement programs that's being done to address the unsustainable rates hurting home medical equipment suppliers. These outdated rates put in place by CMS have failed to consider the increased cost of providing care and are impeding home medical equipment suppliers' ability to offer home-based care. I recently heard from a number of suppliers in my district, Flower Mound, Irving, and Fort Worth, on the importance of this in respiratory services. This employer has served 1,600 constituent Medicare patients in the last 12 months in my district. We should continue to support those providing healthcare services while making certain that the reimbursement is balanced. And I'll yield back to the gentlelady from Iowa.
Will the gentlelady yield?
Yes, I'll yield.
I would also like to speak out in support of this. It's a critical access issue for the people that I represent in Southwest and West Central Indiana. I hear almost daily about this issue, and it's extremely important that we provide proper reimbursement for these services. Otherwise, citizens that we all represent are going to lose access, which is really a critical problem. So I'm in full support of this legislation, and I yield back to Dr. Miller-Meeks.
Thank you very much, Mr. Chair. I yield back.
Gentlelady yields back. Anyone seeking ready to speak on the bill?
Yes, Mr. Chairman, I move to strike the last word.
Gentleman is recognized.
And express my concerns with the bill. H.R. 5555 extends a program to artificially prop up payment rates for durable medical equipment, exempting them from the full effect of the DME competitive bidding program. And the DME competitive bidding program was passed into law over 2 decades ago by a Republican Congress in the Medicare Prescription Drug Modernization Improvement Act of 2003. In 2020, in response to the pandemic, Congress provided temporary relief for DME suppliers to address the reimbursement challenges posed by COVID-19. And this relief expires at the end of this year. And now we're being asked to extend this temporary relief again and create a new extender policy that Congress will have to continue to address in the future and find bipartisan offsets. Additionally, extending these higher rates will result in increases in out-of-pocket costs for our Medicare beneficiaries. Although Republicans want to extend this temporary relief program to help the durable medical equipment industry, the majority continues to refuse our request to move legislation to extend another important program that actually directly helps Medicare beneficiaries and has historically been bipartisan. And that's H.R. 5630, the Helping Low-Income Seniors Afford Care Act, led by Representative Craig, which extends existing programs, the state health insurance assistance programs, the area agencies on aging, and the National Center for Benefits Outreach and Enrollment to help low-income Medicare beneficiaries enroll in Medicare and access benefits that lower their out-of-pocket costs. Now, these outreach and enrollment programs help our nation's most vulnerable low-income beneficiaries access assistance for prescription drug coverage and other essential Medicare benefits. Because of these programs, approximately 3.5 million Medicare beneficiaries have received assistance, and the number of seniors enrolled in the low-income subsidy program increased from 11.8 million in 2014 to 14.2 million in 2020. A broad coalition of 57 organizations support the extension and expansion of the outreach and enrollment programs, which have been extended 11 times with bipartisan support over the past 15 years. But Republicans refused to extend funding for these programs in the continuing resolution, allowing them to lapse this past September. So I'm extremely disappointed that Republicans failed to include the bill in today's markup and are continuing to placate the extreme elements of their party, even with programs with longstanding bipartisan support. And I'm disappointed today to have to urge my colleagues to vote no on this measure, but I want to send the message loud and clear to our colleagues on the other side. You can't hold programs like this one hostage and expect Democrats to just work with you on Republican priorities. And while I'm disappointed the bill was not included in today's markup, I will continue to fight to lower costs and expand access to care for Medicare beneficiaries and oppose policies that would result in increased premiums or additional out-of-pocket costs for seniors. So I urge members to join me in opposing H.R. 5555. And with that, I yield back, Mr. Chairman.
Gentleman yields back. Anyone seeking recognition to speak on the bill? Dr. Bouchon from Indiana is recognized.
Yeah, Mr. Chairman, thank you. I want to speak on the bill. I'll be brief. I respect my colleagues' comments, but it's apples and oranges. Access to programs doesn't work if the programs don't exist. And so legislation like 5555 is ensuring that we actually have people out there that provide these services to seniors. I'm empathetic to his comments, but it's apples and oranges, and I think holding separate things hostage because of partisan differences on another piece of legislation is the wrong approach. With that, I yield.
Gentleman yields back. The gentlelady from California is recognized for 5 minutes to speak on the bill.
Thank you, Mr. Chairman, and I move to strike the last word.
Gentlelady's recognized.
Thank you. I recall a very long time ago, but it was really taking on a huge issue by Energy and Commerce Committee on durable equipment, and the whole issue of not only the cost, but the industry rife with corruption. I mean, the private sector ripping off the public sector, and the costs were tremendous. This committee did, I think, extraordinary work on the issue, and now we have this bill. Really, at the heart of this bill is the rate being paid for certain products. We increased the rate as a part of COVID relief. Now that the public health emergency is over, I think we need to get this program back on track to lower prices that beneficiaries have to pay both out of pocket, lower taxpayer spending, and protect the Medicare Trust Fund from fraud. So while I'm not going to vote for this bill today, I'd be more than happy to continue to work on DME policy so that we put the DME program back on track after, as COVID has, thank God, diminished, because we need to make sure that beneficiaries still receive the quality equipment they need. Now, the previous payment system was 75-25. This bill takes it to 90-10. And I think there's more work to be done on this bill. I think some of the sentiments that have been expressed by members on behalf of their constituents, have merit. But I don't think the way the bill is structured is really the right way to go, and that's why happy to work on this. We have extender policies that we've neglected to move, and I mentioned those in my opening statement. But this one, from 75-25 on payment to increasing it to 90-10. So with that, I yield back.
Would the gentlelady yield?
No, I'm going to yield to Congresswoman Trahan, and if she doesn't use all the time, then we'll go to you.
Well, thank you, Ranking Member Eshoo. Look, in the district I represent, the DME competitive bidding program has caused issues for home care patients' access to medical equipment. Since this new program was established in 2013, many DME suppliers have gone out of business, causing home care agencies to sound the alarm about how difficult it's become to obtain some of the most basic equipment like walkers and wheelchair hospital beds. If this program isn't updated, we will most certainly continue to see increased lack of access for home care patients. The majority has decided to take what could and absolutely should be a bipartisan issue and play politics with it, and I'm disappointed at the refusal to include the reauthorization of the State Health Insurance Assistance Program for this subcommittee to consider today, a program that each of our states across the country benefit from. For this reason, I will not be able to support the underlying legislation today, and moving forward, I sincerely hope that my Republican colleagues choose to work with us as we move important policies through the legislative process, so it can be done the right way the first time around. Thank you. I yield back.
Gentlelady yield? Yeah, I fundamentally agree with Ms. Trahan on what her comments. I mean, the competitive bidding process sounded like a good idea, but the problem is without proper oversight of the process, it resulted in all the things Ms. Trahan just said, where less providers were available. We had people who were winning bids and then were basically storefronts and couldn't provide the product to seniors. It's again, it sounded good in practice, but the competitive bidding process has not worked, and therefore this is why we're stuck with having these fixes to make sure that we don't have further access problems to the program. I yield back.
Gentlelady yields back.
I do.
The gentlelady yields back. Is anyone else seeking recognition for the gentlelady from Minnesota is recognized for 5 minutes to speak on the bill?
Thank you, Mr. Chairman. I move to strike the last word. Thank you. I just wanted to take a moment to express some frustration here. I know my Republican colleagues have brought before us one program extension, but you've entirely forsaken another. The state health insurance programs, the area agencies on aging, aging and disability resource centers, and the National Center on Benefits Outreach and Enrollment provide critical Medicare low-income outreach and enrollment efforts that must be reauthorized by Congress every few years. As a matter of fact, in the past 15 years, these programs have been extended 11 times with bipartisan support. This year, these program authorizations expired on September 30th. While their resources have not been fully depleted, without timely reauthorization, funding for these programs will dry up by the end of this year. Every member in this room has constituents that benefit from these programs. In fact, in 2022, over 111,000 Minnesotans were assisted by our state health insurance program. This year alone, more than 97,000 Minnesotans have benefited. And as of February of 2023, a total of about 3.5 million Americans in need received assistance from these navigators. We've had the opportunity to include my bill, the Helping Low-Income Seniors Afford Care Act, in this markup. My bill would make these authorizations permanent so that our seniors and those with disabilities on Medicare do not have to suffer because of political gameplay. We've asked for a hearing on the bill multiple times before today, but instead of encouraging an open dialogue on the issue, my colleagues have decided to exclude it from the notice list of bills again. So make no mistake, the looming lapse in these critical funds is a real problem. These authorizations enable our nation's most vulnerable Medicare beneficiaries to be connected to coverage, and it's really unforgivable that my colleagues continue to obstruct them. In closing, Mr. Chairman, I would ask for unanimous consent that a letter signed by 57 national aging, disability, patient, and provider organizations supporting continued funding for Medicare low-income beneficiary outreach and enrollment efforts be entered into the record. And with that, Mr. Chairman, I yield back.
The gentlelady yields back. Anyone else seeking recognition on the bill? Are there any bipartisan amendments to the bill? Are there any other amendments to the bill? Seeing none. The question now occurs on forward in H.R. 555 to the, let's say all the 5555 to the full committee. As all those in favor shall say aye. I believe a roll call has been requested. So the gentleman requests a roll call vote. The clerk will call the roll.
Guthrie.
Aye.
Guthrie votes aye. Burgess. Burgess votes aye. Latta. Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Johnson. Bouchon. Bouchon votes aye. Hudson. Hudson votes aye. Carter. Carter votes aye. Dunn. Dunn votes aye. Pence. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshu. Eshu votes no. Sarbanes. Sarbanes votes no. Cardenas. Cardenas votes no. Ruiz. Dingle. Dingle votes no. Custer. Kelly. Kelly votes no. Barragan. Barragan votes no. Blunt Rochester. Blunt Rochester votes no. Craig. Craig votes no. Schreier. Schreier votes no. Trahan. Trahan votes no. Pallone. Pallone votes no. Chair Rodgers. Chair Rodgers votes aye. Mr. Ruiz, you're not recorded. Ruiz votes no. Mr. Johnson, you are not recorded. Johnson votes aye.
Anyone not having a chance to enter the roll call? Seeing no one else, the clerk will report.
Chair Guthrie, on that vote, there were 16 ayes and 12 noes.
With 16 ayes and 12 noes, the ayes have it and the bill is agreed to. Now, sticking with kind of our fluid schedule, we're going to move to the last bill on our agenda today. Not our last bill, the listed last bill. We're going to do others after this one. But the chair will call up H.R. 1691 and ask the clerk to report.
H.R. 1691, a bill to amend Title 18 of the Social Security Act to ensure prompt
Without
coverage.
objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point, so ordered. And I will recognize myself for 5 minutes to speak on the bill. This bipartisan legislation, which is supported by 20 Energy and Commerce Committee members, including Ranking Member Eshoo and me, and I, will provide access to breakthrough devices for seniors with limited or no alternative treatment options for a life-threatening condition. The legislation follows extensive work by the Trump administration on the Medicare Coverage of Innovative Technologies rule, which was repealed and replaced by a Biden administration rule that will not meaningfully lead to greater access to care for patients. H.R. 1691 is needed to ensure seniors have access to these novel therapies more quickly. Recent reporting shows it takes an average of 5 years for medical devices to reach patients in the Medicare population. To meet the criteria for breakthrough device designation, a device must deliver a more effective treatment or a diagnosis for patients facing life-threatening or irreversible debilitating diseases or conditions. In addition, the device must also provide significant advantage over approved existing alternatives, be in the best interests of patients or fill a gap where no approved alternatives exist. This is a reasonably high standard to meet for device developers, which is why it is so important that a streamlined pathway to coverage exists for these patients. If a product meets eligibility criteria, why should a senior need to wait 5 years to gain access to a potentially life-saving or life-altering product? Importantly, the bill will also get more cost-effective products to market sooner by encouraging investment in these diseases. I encourage my colleagues to support this broadly bipartisan bill. I also know we are working through potential offsets to the legislation, and I look forward to ensuring the legislation is paid for before full committee. Thanks, and I yield back. Anyone else seeking discussion? The gentleman from New Jersey is recognized on the bill to speak for fight.
Thank you.
Oh, you. Okay.
Thank you, Mr. Chairman. I want to express my strong concerns with H.R. 1691. The bill would hamper the Centers for Medicare and Medicaid Services' ability to prioritize the health and safety of Medicare beneficiaries and undermine Medicare's standards for determining coverage of medical devices. CMS plays an important role in ensuring that Medicare beneficiaries can access medical devices in a timely manner while maintaining appropriate safeguards and rigorous evidence standards that prioritize the health and safety of Medicare beneficiaries. Earlier this year, CMS proposed the Transitional Coverage for Emerging Technologies, or TCET, pathway to provide a pathway for coverage of emerging technologies to strengthen the evidence necessary to ensure coverage. The TCET pathway will allow CMS to collect real-world evidence and help address evidence gaps to support Medicare coverage through a predictable and transparent process for medical devices with limited or developing evidence in the Medicare population. The TCET pathway ensures the agency has the opportunity to review all the available evidence and collect additional real-world data to make necessary coverage determinations, particularly since the Medicare population is different from the general population and is sicker and with more comorbidities. And these considerations are often not addressed in the early device development process. I'm concerned that H.R. 1691 would require immediate and automatic coverage of breakthrough devices, undermining both the TCET pathway and circumventing CMS's reasonable and necessary process for coverage. Now, I have to note that breakthrough is a designation given by FDA at a very early stage in development when early evidence suggests that it may treat some condition where there are no other device alternatives or when there is a reasonable expectation that a device may offer advantages over existing alternatives before an application for the device is even submitted. The device retains the breakthrough designation even if evidence later on indicates otherwise. So H.R. 1691 would guarantee a fast track to Medicare coverage when there is limited evidence of additional benefit and would make it impossible for CMS to collect real-world data and evidence, as industry will not have any incentive to provide the evidence given the automatic and immediate coverage. Beneficiary groups, including the Center for Medicare Advocacy, have expressed concerns with the bill writing, the way it's written, because it would result in unintended consequences and potential safety issues due to bypassing the long-established CMS approval and vetting process. Now, despite these major issues with the bill, the industry has refused to engage productively on a bipartisan consensus policy. They've refused to build on the Biden administration's TCET proposal, which is intended to expedite coverage of breakthrough devices through a predictable and transparent process while safeguarding patient safety. And I believe the TSET proposal provides a good evidence-based framework to address evidence gaps to support Medicare coverage and ensure seniors have access to high-quality, safe technologies. However, it appears that the industry is only willing to support codifying the Trump administration rule, which will require immediate and automatic coverage of breakthrough devices instead of trying to build bipartisan consensus and work with this administration. I think that's unfortunate. But in addition, the Congressional Budget Office has informally estimated that the cost of H.R. 1691 would be at least $7 billion and as high as $12 billion. Enacting this proposal would likely result in significant cuts to the Medicare program in order to offset spending of this magnitude. The Republican majority has put forward this bill without any proposed bipartisan pay-fors, and I'm concerned that such a policy will raise premiums for Medicare beneficiaries. So I'm going to continue to oppose any efforts to increase beneficiary contributions or raise premiums, cut Medicare benefits, or enact spending cuts to the Medicare program, or pay for the policy on the backs of Medicare providers. This policy is simply not good for beneficiaries. It hinders CMS's ability to ensure patient safety and gives billions of dollars to the device industry at the expense of seniors' health and well-being. So I would urge members to join me in voting no, and with that, Mr. Chairman, I yield back.
The gentleman yields back. Is anyone seeking recognition and discussion on the bill? The gentleman from Florida is recognized for 5 minutes for the
Thank you, Mr.
purpose of
Chairman.
discussion of the bill.
Thank you. I'm asking my colleagues to support H.R. 1691, the Ensuring Patient Access to Critical Breakthrough Products Act, legislation I sponsored, again, with Representative Winstrup on the Ways and Means Committee, which I've been proud to co-lead on behalf of our jurisdiction here in the Energy and Commerce Committee. I'm very excited to be moving this legislation forward through the subcommittee here today. Our critical legislation has a strong bipartisan support, I might add, from many members of the Energy and Commerce Committee and the subcommittee, including Chair Guthrie, Ranking Member Eshoo, as well as Representative Cardenas. It will ensure prompt Medicare coverage for medical devices approved by the FDA under the Breakthrough Devices Program. As we heard in our legislative hearing on medical innovation, it is crucial we provide Medicare beneficiaries with the access to treatments and cures that are being developed for patients in need, particularly those who have debilitating, life-threatening diseases where no alternatives exist. In the Trump administration, led by HHS Secretary, my good friend, Mr. Azar, they recognize the need for providing a pathway to coverage for life-saving devices technologies by proposing the Medicare Coverage of Innovation Technology, or MCIT rule. This rule provided a Medicare coverage pathway of breakthrough devices for 4 years, starting on the date of the FDA market authorization. It also clearly outlined a process for national coverage determination for device manufacturers. Unfortunately, despite broad bipartisan support for this rule, the Biden administration repealed MCIT, that particular rule, in a misguided, in my opinion, attempt that has set back efforts to spur innovation for treatments of severe, serious diseases. Instead, they have replaced it with a transitional coverage of emerging technologies, or TSET pathway. While I appreciate the intent of allowing a new pathway, this current TSET rule is filled with CMS bureaucracy and caveats that hamper innovative technologies from being covered in the marketplace. H.R. 1691 will finally provide certainty to the industry and give a true pathway to coverage by reestablishing the 4-year transitional coverage period and expediting CMS decision-making on national coverage determinations and payment codes. Our bill also includes a pathway for devices without existing benefit categories. Ultimately, we want to incentivize additional breakthrough technologies to come to the market faster and get into the hands of seniors who can greatly benefit from them. I'm grateful to the chair again and the ranking member for their support on this particular bill, and the ranking member of the subcommittee, and I know the chair of the full committee supports it as well. I'm hopeful we can get this across the finish line and provide a statutory pathway for these emerging medical technologies for the sake of Medicare patients nationwide. And I urge passage of this particular
Will the gentleman
bill.
yield?
And, yeah, I will yield.
Gentleman yield? Here, Gus.
Yes, I will
Yep.
yield, yes.
Great,
Oh, here we go, right over here. Yes, absolutely, I'll yield
I'll be
to the
brief.
doctor, the good doctor.
I'll be brief.
Okay.
I want to put a take on this situation from a patient's perspective. If you're a family and a patient out there, there's an FDA-approved device that has been shown to be safe and also effective, but it's going through this pathway to get it to patients faster. And then you come to find out that it might take 4 or 5 years for you to get access to this device or treatment. That's not just hypothetical. That recently happened, and it took 4 or 5 years for patients to get access to a medical device that would extend people's lives with glioblastoma for 18 months. And if anybody knows about that disease, they know that 18 months is a lifetime for yourself and for your loved ones. So CMS needs to cover these things if they're FDA approved, they're shown to be safe, and this legislation is necessary. It makes no sense at all to have every other coverage, private sector, even the VA, cover these things and take 5-6 years to get these to seniors. It's limiting access, and it's actually costing us lives. I yield back.
Thank you, I appreciate the real-world explanation, and I yield back, Mr. Chairman.
Gentleman yields back. Anyone seek a recognition? The gentlelady from California recognized for 5 minutes on the bill.
Thank you, Mr. Chairman. I move to strike the last word to speak on the bill. I think that it's worth appreciating that the issue and the reason for this legislation has been a long time in coming. I remember working with, on a bipartisan basis to get the FDA to move in a timely way, and it was because of this committee, legislation that I did on a bipartisan basis to correct the ills in the FDA at that time, more than a decade and a half ago, for timely approvals on medical devices. 3 administrations have worked on this issue, the issue of CMS dragging their heels. So we have really fixed the FDA side, but it takes, 5-6 years on average for CMS to weigh in and to do what they do. So this is not timely, and it's not access. And that's what this legislation is about. Now, this committee completed the work through the 21st Century Cures Act. That created the Breakthrough Devices Program at the FDA. So a lot of work has gone into this. This legislation is not about every application and approval of a medical device at the FDA. That's not what it's about. It's about the special program. Now, of the 828 devices that have applied for designation since 2019, which is 4 years ago, 81 have made it through FDA review and to the market. So this is not a speedy program. And the scrutiny, we all know the scrutiny that devices are subjected to by the FDA. And that's as it should be. So many of these devices are inserted inside the body. Now, while Medicare beneficiaries wait for Medicare to cover these life-saving technologies, they're either denied care or they face high out-of-pocket costs while their doctors fight through the paperwork to get Medicare to pay the claim. Those that don't agree with this policy don't ever mention the denial of these devices in life-saving situations. The Stanford Buyers Center in my district found that the only factor that statistically significantly predicted Medicare finally covering a breakthrough device, are you sitting down? It wasn't clinical evidence, but it's the size of the device's manufacturer, because time is money. So if you want the most breakthrough devices to be approved on a timely basis, the FDA, through Dr. Shuren heading up that part of the FDA, has done yeoman's work on that. We need CMS to do the same. So this is about access and life-saving. This is not every single medical device that's approved by the agency. And importantly, the bill makes clear that if at any time during the temporary coverage period, Medicare determines that a device offers no benefit or may cause harm to beneficiaries, then Medicare can terminate that coverage. So I think all four corners are covered in this. And I simply don't view this being a bad and dangerous policy. I think it's wholly the opposite. This is life-saving for Medicare beneficiaries. Why should they have to wait 5 or 6 years? Why? It's just that the agency is doing that. There isn't any good reason for it. So I'm pleased to be on this legislation with colleagues on both sides of the aisle. It's worthy of the support of the Health Subcommittee, and we send that positive vote to the full committee and hopefully get this bill done across the finish line and into law. Seniors deserve it, and I yield back.
Gentlelady yields back. Anyone seeking recognition for discussion of the bill? Gentleman from California, you're recognized for 5 minutes.
Thank you. Well, regarding this bill, I believe it's well-intentioned. It was a fast-track way to get breakthrough medical devices into the market with urgency to address the needs during the pandemic. And I understand it, and I think it's a good intention. My concern is that there are not enough patient safety monitoring, and also we don't know what the pay-fors are in its final form, and I don't want to rob Paul to pay Peter. So today I will be voting no, but I welcome further conversations on those issues before the full committee markup or the House votes. I also am going to take a moment of privilege while I have the mic to ask for unanimous consent to insert my remarks for H.R. 6371, the Provider Reimbursement Stability Act, to the record in support of the bill, as well as my bipartisan bill with Drs. Bouchon and Miller-Meeks, the Strengthening Medicare for Patients and Providers Act, H.R. 2474, and thank you, and request that this committee bring it up at the next markup. And I yield my time to Mrs. Dingle.
Thank you, Mr. Ruiz. I just want to expand or go on top of Mr. Ruiz's remarks about how our nation's come a long way in the development of new medical devices. They've got the ability to revolutionize the healthcare industry, improve patient outcomes, and quite frankly, they're going to save lives. But as we identify ways to facilitate access to cutting-edge medical devices, we got to make sure it's done in a way that's based on strong evidence standards. I love and have tremendous respect for my colleagues who are leading this bill, but as it's currently written, I fear it may undermine this goal by hamstringing the Centers for Medicare and Medicaid Services' ability to maintain appropriate safeguards for new medical devices, but will raise Medicare premiums for seniors. So to be clear, I firmly believe that we need to help CMS decrease the time. We've got to make it faster between the Medicare coverage determination process and patients' access to innovative devices. September, CMS and the U.S. Government Accountability Office is committed to working with this committee on solutions to improve and expedite this process. Want to support that strongly. Medicare beneficiaries should have confidence that the devices they're using are held to rigorous evidence standards, that can access these important devices as quickly as possible, and that their premiums aren't going to spike in the process. So while I can't vote for this bill yet today, I want to work with all of my colleagues to find ways that we're going to be able to expand access to high-quality care for all seniors, and thank them for the work that they're doing, and hope we get there by the time this gets to full committee. Thank you, and I yield back to Mr. Rush.
And I yield to Ranking Member Pallone.
Thank you. I don't want to add too much to what I said before, but I do want to stress that the Biden administration came up with this TSET alternative, rather than just say, look, in this case, if the FDA approved it and it's designated breakthrough, then the CMS process is just essentially overridden. And I think that has all kinds of pitfalls. The TSET process, which I understand has only been in effect, maybe about a year or less, is a way of trying to cut back on the length of time it takes to approve these things, but without taking CMS out of this process completely. And I think that somehow the notion is out there that, well, once FDA designates this as breakthrough, that's enough, and there's no need for the CMS process at all, and that's where I disagree. I think there is some value in the CMS process if we can expedite it through TSET, which really hasn't had much of a chance yet, then we could hopefully reduce the amount of time. But to just eliminate that completely, and particularly in a situation where we know we're talking about, $7 to $10 billion without any kind of offset, and I don't see how we're going to come up with an offset of this magnitude, is only going to result in increased premiums without having the opportunity for CMS to take a look. And they're going to look at this not only from the question of how helpful these products are, but also, to what extent the Medicare program can effectuate it and make it available to everyone. And I think that's necessary. So I don't want to add any more, but I just urge my colleagues to vote no and thank the gentleman from California. Yield back.
Any other discussion? Does anyone seek recognition to discuss the bill? Are there any bipartisan amendments to the bill? Seeing none, are there any?
Mr. Chair, I just wanted.
Oh, I'm sorry, I didn't see you get recognized. Mr. Sarbanes, you're recognized for 5 minutes.
Yeah, I don't have a lot to add. I just wanted to emphasize a couple points that others have made. One is the well-intentioned efforts behind this bill. I certainly understand that. We have competing considerations here, both of which have merit. One is to accelerate coverage of these devices. The other is to make sure that the information that's being gathered up, that process is robust and creates a positive feedback loop into the overall process to make sure that patients, yes, the ones we want to get this coverage to and these devices to and this support to, but that what's being delivered is based on good information at the same time. And it's not like we're starting from like a full stop here. The TSET proposal that the administration has put forward is trying to achieve both of those things. It's trying to accelerate the process on the one hand, and it's trying to make sure we have good data information to inform that for the benefit of the patients out there that need this as we move along. So I very much agree that it's striking the balance that we need here to accommodate both of those differing perspectives and considerations. And for that reason, I share the ranking members and others members' reservations about moving ahead with this, and I yield back my time. Yeah, I'll yield.
Thank the gentleman for yielding. I think something that's very important to, restate, because I think it's been stated, is the following. CMS does approve some of these. So for those that think this is a whole new process that's being set up so that CMS can approve, they already are. So this isn't something new. They already are. There's a stringency to it, and there should be. And there should be, both by FDA and by CMS. What's at the heart of the bill is taking 5 to 6 years to get an approval on the CMS side. And as the study that I referenced found that the only factor that statistically significantly predicted Medicare finally covering a breakthrough device was not clinical evidence. It was the size of the device's manufacturer. We need to do better than this. So for those, and I respect my colleagues, however they're going to vote, but I think the information thinking that it's understood, thinking that it's a whole new process that CMS has to take up according to this bill, that's not what the bill does. It's not what the bill does. With that, I yield back, and I thank the gentleman for yielding.
Yeah, and I yield back my time.
Gentleman yields back. Does anyone else seek recognition on the bill? Are there any bipartisan amendments? Are there any other amendments? Seeing none, the question now occurs on forward in H.R. 1691 to the full committee. All those in favor will say aye.
Mr. Chairman, I'd ask for a roll.
The roll call is requested. Clerk will call the roll.
Guthrie.
Aye.
Guthrie votes aye. Burgess. Burgess votes aye. Latta. Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon. Bouchon votes aye. Hudson. Carter. Carter votes aye. Dunn. Pence. Pence votes aye. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Obernolte. Obernolte votes aye. Eshu. Eshu votes aye. Sarbanes. Sarbanes votes no. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes no. Dingle. Dingle votes no. Custer. Kelly. Kelly votes no. Barragan. Barragan votes aye. Blunt Rochester. Blunt Rochester votes no. Craig. Schreier. Schreier votes aye. Trahan. Trahan votes aye. Pallone. Pallone votes no. Chair Rodgers. Chair Rodgers votes aye.
Does the clerk call the names of those who have not been recorded?
Hudson is not recorded.
Hudson votes aye.
Hudson votes aye.
Ms. Craig, how's Ms. Craig recorded?
Craig is not recorded. Craig votes aye.
Anyone else seeking? Seeing no others making some present, the clerk will report.
Chair Guthrie, on that vote, there were 21 ayes and 6 noes.
With 21 ayes and 6 noes, the ayes have it, and the bill is agreed to. The chair calls up H.R. 5388 and asks the clerk to report.
H.R. 5388, a bill to amend Title 18.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered, and I will recognize myself for 5 minutes to speak on the bill. The Supporting Innovation for Seniors Act expands flexibility for Medicare Advantage plans to increase access to innovative products. Value-based insurance design, or VBED models, let MA plans test programs that provide better care or lower costs. One flexibility in this model lets MA plans provide access to FDA-approved medical device or technology, either for the first time or to cover a new indication beyond the Medicare coverage determination. One MA plan is using this to offer coverage of continuous glucose monitoring devices for patients with diabetes and remote patient monitoring devices for patients with congestive heart failure. These types of RPM programs score high on patient satisfaction by empowering them to have at-home control over their conditions. They also improve coordination and allow providers to prevent catastrophic events. but we should not limit these benefits to patients in discrete plans in the VID model. This bill would permanently expand these flexibilities to allow MA plans to offer these to any patient. Regulatory hurdles should not get in the way of MA plans offering ways to lower costs and improve health care, and I encourage my colleagues to support this bill, and I will yield back. Is anyone seeking discussion of the bill? Seeing no discussion, Dr. Schreier, one. This is 5388. 5388. Mr. Gentleman from New Jersey, recognized for 5 minutes.
Thank you, Mr. Chairman. I want to express my strong concerns with H.R. 5388. More beneficiaries are now enrolled in a Medicare Advantage plan than traditional Medicare, and it's critical that we prioritize the health and safety of beneficiaries enrolled in these plans. The Centers for Medicare and Medicaid Services plays an important role in ensuring that Medicare beneficiaries enrolled in Medicare Advantage plans can access medical devices and treatments in a timely manner. Currently, Medicare Advantage plans have significant flexibility to offer a wide array of services as supplemental benefits. Under the value-based insurance design model, Medicare Advantage plans have additional flexibility to offer benefit designs and supplemental benefits not covered by traditional Medicare. But I'm concerned that H.R. 5388 would bypass CMS's regulatory pathways to coverage and undermine Medicare's safety standards to give handouts to the medical device industry. The bill would allow Medicare Advantage plans to provide coverage for any medical device or technology, including for devices that have not been approved under the agency's coverage pathways and for an indication that is different than already approved. Additionally, the bill does not include important guardrails from the VBID model, such as ensuring that the technology is primarily health-related or that the supplemental benefit has a reasonable expectation of improving or maintaining the overall health of beneficiaries. So I'm concerned that the bill would lead to Medicare coverage of untested medical devices and would jeopardize the safety of Medicare beneficiaries. Beneficiary groups such as the Center of Medicare Advocacy have also expressed significant concerns with the bill writing that it would, and I quote, compromise safety of beneficiaries. I'm also concerned that the bill could raise premiums and healthcare costs for Medicare beneficiaries. It's disappointing that my Republican colleagues are prioritizing helping the device industry instead of helping lower seniors' health care costs. I'm not sure I understand what problem this bill is trying to solve. My understanding is that participation in the demonstration has been lackluster and that MA plans already have more than enough flexibility to expand supplemental benefits under current law. Moreover, I understand that Medicare Advantage plans are not even particularly interested in covering devices for indications different from the FDA approval because of the safety concerns. So I think this bill is a solution in search of a problem, but I will continue to see if it is at all possible to find any bipartisan common ground before the full committee. And with that, I yield back, Mr. Chairman.
Gentleman yields back. Anyone else seeking discussion on the bill? Seeing none, are there any bipartisan amendments to the bill? Seeing none, any amendments to the bill? Seeing none, the question now occurs on forwarding H.R. 5388 to the full committee. All those in favor say aye. Aye. All opposed say no.
No.
The ayes have it, and the bill is agreed to. The chair calls up H.R. 5380 and asks the clerk to report.
H.R. 5380, a bill to amend Title 18 of the Social Security Act to increase data transparency.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition to speak on the bill? Gentleman from New Jersey. I don't know why I said New Jersey. Gentleman from Maryland is recognized for 5 minutes.
Thanks very much, Mr. Chairman. I move to strike the last word. This bill is a common sense measure to increase transparency in the Medicare Advantage market, which provides coverage, as we all know, to 30 million Americans, or more at this point, more than half of the population that's actually enrolled in Medicare or eligible for it. Despite this huge market share, data collection, as we know, on the supplemental benefits provided by these Medicare Advantage plans is inconsistent across the plans, and that makes it difficult to evaluate scope, utilization, cost of the benefits, and so forth. I introduced this bill to change that by simply requiring that MA plans report enrollee level data on the categories of benefits provided, the eligibility for those benefits, the utilization of certain benefits and costs, both costs paid by the plans and out-of-pocket costs paid by beneficiaries for services. So this is basically just to get more information into the mix again so we can make better judgments. It would also require data to be made publicly available online on an annual basis so that policy experts can better understand the value of these policies and seniors can choose the plan that is right for them. More sunlight will lead to better outcomes. This does not change, I want to emphasize this, any requirements on the types of supplemental benefits that Medicare Advantage plans can offer. It simply requires that if you're going to offer them, our seniors need to have the data to effectively evaluate them. So as we continue our work to make healthcare more accessible and affordable for all Americans, including seniors living on fixed incomes, I urge my colleagues to support this sensible reform and vote in support of H.R. 5380, and I yield back my time. Thank you.
Gentleman yields back. Anyone seeking recognition? There's further discussion on the bill. Are there any bipartisan amendments? Seeing none, are there any other amendments? Seeing none, the question now occurs on forwarding H.R. 5380 to the full committee. All those in favor will say aye. Aye. Those opposed, no. The ayes have it, and the bill is agreed to. The chair calls up H.R. 3842 and asks the clerk to report.
H.R. 3842, a bill to amend Title 18 of the
Without objection, the first reading of the bill is dispensed with, and the bill is open for amendment at any time, so ordered. Does anyone seek recognition on the bill? Are there any bipartisan amendments? Gentlelady from Washington, recognized for your amendment.
Thank you, Mr. Chairman. I have an amendment at the desk.
The clerk will report the amendment.
Amendment in the nature of a substitute
Without
to H.R.
objection, the reading of the amendment is dispensed with, and the gentlelady is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman. I want to thank our committee leadership and Mr. Bilirakis for working to move this proposal forward. The Expanding Access to Diabetes Self-Management Training Act is a bipartisan and bicameral bill that aims to make small but meaningful tweaks to diabetes self-management training to make it more accessible and more effective. The training teaches patients good practices to manage their condition and to hopefully prevent or mitigate complications down the line. I can speak to the importance of this training as a physician and also as a patient who has lived with type 1 diabetes since age 16 and still remembers my initial trainings. It is critical that our seniors have easy access to this training and are actually utilizing it. Currently, only about 5% of Medicare beneficiaries who are newly diagnosed with diabetes even utilize the benefit, which is terrible. Diabetes self-management training empowers patients and allows them to live the longest and healthiest possible lives. These trainings are essential to lowering both the human and financial costs of this disease on our seniors, their families, and the Medicare system. That's why my bill with Mr. Bilirakis works to ensure that various kinds of providers are able to refer their Medicare patients for this training. It also ensures that Medicare beneficiaries can receive 10 hours of initial training. And I look forward to continuing to work on this bill with Mr. Bilirakis and committee leadership to ensure that qualified non-physician practitioners can also refer for these services and that we make these services as accessible as possible. I encourage my colleagues to vote for this bill, and I yield back.
Thank you. Dr. Schauer yields back. Is there any discussion on the amendment? Seeing none, are there any other amendments? Gentleman from Ohio is recognized.
Mr. Chair, I have an amendment at the desk.
Clerk will report.
Amendment to the amendment in the nature of a substitute to H.R. 3842, offered by Mr. Johnson of Ohio. Add at the end the following new sections.
Without objection, the reading of the amendment is dispensed with, and the gentleman is recognized for 5 minutes in support of the amendment.
Mr. Chair, simply put, my amendment would ensure that Medicaid patients across the country have access to life-saving podiatric medicine by including H.R. 1634, the HELP Act, The federal Medicare definition of physician has included podiatrists for nearly 60 years. However, under Medicaid, there is no such inclusion of DPMs. For years now, alongside my friend and colleague, Congresswoman DeGette, I have made this a priority. Ensuring access to these life-saving treatments is so desperately needed, especially in rural America. Any discussion surrounding diabetic health must include access to DPMs. Not to mention, the legislation would facilitate a net cost savings for the system. 67 bipartisan co-sponsors have already signed on in support of this legislation, including 11 other members of this subcommittee and 19 on the full Energy and Commerce Committee. I want to thank all those members for lending your support for this bill. That said, Mr. Chairman, with your commitment to work with me on moving this forward, I would be willing to withdraw this amendment.
Look forward to working with you.
Okay, I withdraw.
The amendment is withdrawn.
And I yield back.
And the gentleman yields back. Are there any further amendments? If not, we need to adopt the amendment nature of a substitute offered by the doctor from Washington. All in favor say aye. Aye. All opposed say no. The ayes have it, and the amendment is agreed to. With no further amendments, the question now occurs on forwarding H.R. 3842 as amended to the full committee. All those in favor will say aye. Aye. All those opposed, no. The ayes have it, and the bill is agreed to. The chair calls up H.R. 5397 and asks the clerk to report.
H.R. 5397, a bill to amend Title 18 of the Social Security Act.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? Seeing none, are there any bipartisan amendments? The gentleman from Florida is recognized.
Thank you, Mr. Chairman. I have an amendment at the desk.
Clerk will report.
So this is...
The clerk will report the amendment.
Amendment in the nature of a substitute to H.R. 5397.
Without objection, the reading of the amendment is dispensed with, and the gentleman from the gentleman from Florida is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman. This amendment in the nature of a substitute seeks to make small technical changes to the underlying bill, and I hope my colleagues will indeed support H.R. 5397, the Joe Fienda Access to Home Infusion Act. I appreciate my colleague, Mr. Fitzpatrick, working with me on this bill. I was moved by the story of the late Joe Fiandra, relayed to me by his wife, who resides in Mr. Fitzpatrick's district. She and her late husband struggled to jump through hoops and travel long distances to access infusions to treat his amyloidosis. When Congress passed the 21st Century Cures Act in 2020, I was proud to support that legislation, and that would preserve and promote innovation and increase access to needed treatments and technologies, including the creation of a home infusion therapy benefit. My bill today seeks to ensure that the intent of the Cures Act is preserved when it comes to home infusion benefit. Coverage policies should not pick winners and losers based on the modality a patient uses. Currently, DME-infused practitioner-administered drugs are not covered by the benefit, excluding a cohort of patients who can safely infuse in their home if they so choose. The Joe Fiandra Access to Home Infusion Act closes this gap, ensuring that patients can enjoy access to the therapy that best suits their needs. I encourage my colleagues to support this common-sense legislation fix, which builds upon the success we had accomplished with the 21st Century Cures Act. I also want to take a moment in my time now to acknowledge my support of another common-sense legislative payment fix. It's the FIND Act. FIND Act was not noticed today, but it was included in the September legislative hearing, and 13 of my colleagues on the subcommittee are co-sponsors. The FIND Act seeks to improve the payment methodology for the use of PET and SPECT scans in the hospital setting. Advanced diagnostic radiopharmaceuticals aid in these procedures, highlighting specific organ systems and producing highly detailed images for precise diagnosis. CMS has solicited for comment 5 proposals which could have remedied the current payment inequity during their rulemaking, but unfortunately elected not to make any of the changes to this payment cycle. I want to note that 137 out of 140 commenters supported the framework of the FIND Act, which would have provided a separate payment for diagnostic radiopharmaceuticals. I appreciate Medicare's attention to the specific issue, and I want to reiterate the importance of Congress continuing to work on this issue, which is critical to patient access. An accurate medical scan matters greatly for patients with prostate cancer, Parkinson's disease, Alzheimer's, and many other conditions. And I appreciate my colleagues' support and look forward to continuing to work with you on this topic. With that, Mr. Chairman, I yield back.
Gentleman yields back. Is there any other discussion on the amendment in the nature of a substitute? Seeing none, if there is no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All those opposed, nay. The ayes have it, and the amendment is agreed to. Is there other amendments? The gentlelady from Michigan is recognized.
Thank you, Mr. Chair. I have an amendment at the desk.
The clerk will report the amendment.
Amendment to the amendment in the nature of a substitute to H.R. 5397.
Without objection, the reading of the amendment is dispensed with, and the gentlelady from Michigan is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chair. This amendment that I've introduced would replace the underlying bill with the text of the Preserving Patient Access to Home Infusion Act, which is legislation I've led with Representatives Buchanan, Sewell, and Harshberger. I have to admit I'm disappointed and quite frankly perplexed about why the Preserving Patient Access to Home Infusion Act wasn't included as part of today's markup. This bill has earned the support of a wide array of stakeholders, advocates, and members, including several on this committee, who've been asking for the technical fix for years. In 2016, the 21st Century Cures Act established a home infusion professional services benefit for Medicare Part B infusion drugs. But despite Congress's intent, the Centers for Medicare and Medicaid Services have improperly implemented this benefit by requiring a nurse to be physically present in the patient's home in order to be reimbursed. This fails to account for the extensive clinical and administrative services that are provided remotely by home infusion clinicians. As a result, provider participation in Medicare's home infusion benefit has dropped shortly, and beneficiaries have experienced reduced access to home infusion over the last several years, which was not the intent. And it's precisely why we've been fighting for the Preserving Patient Access to Home Infusion Act. It provides technical clarifications that will remove the physical presence requirement, ensuring payment regardless of whether a healthcare professional is present in the patient's home. The legislation also acknowledges the full scope of professional services provided in home infusion, including essential pharmacy services, into the reimbursement structure. When given the choice, we know patients would overwhelmingly prefer to receive care at home, which can result in significant savings for patients and the providers. Home infusion services offer so many benefits to the patients, from reducing the threat of infection, increasing access in rural communities, lessening transportation challenges, and so much more. As we discuss ways to bring more infusion drugs into this benefit, it's frustrating we're not also ensuring that the existing home infusion benefit is working properly. And that's exactly why the Preserving Patient Access to Home Infusion Act does, or that's what it does. I remain committed to advancing the Preserving Patient Access to Home Infusion Act and would like to work with the chair to continue working on this legislation together to ensure CMS gets the home infusion benefit right. So with that, I am prepared to withdraw my amendment. But before I end this, I also have to make this point again. This has become such an issue for me because I did have to have home infusion drugs. Most of you didn't know I was walking around with a pick in my arm for 3 months, which is another way to administer drugs. You don't have to have a pump. Because of osteomyelitis, I had to get antibiotics through a PICC line, which is a long catheter, for several months. I gave the injection to myself. I didn't pay somebody to come to the house and give it to me every day. It saves a whole lot of money, and it was safe, and unfortunately for some, but for most of you, I'm still walking around okay. So I think it's this method of administration of home infusion drugs can often be safer and easier for patients when it's an option. So while we're examining ways to bring new home infusion drugs into the benefit, I urge all my colleagues to not limit them to only drugs administered through the pump, and I would ask the chairman if he would work with me and the rest of my colleagues as we move this
We
forward.
look forward to trying to work together to come to this.
Thank you, Mr.
Will
Chairman.
the gentlewoman yield?
Yes.
I'm so pleased to see that you're walking around, and I love you very much, and we'll see you around for a long, long time. And thank you for sharing that important story. I yield back.
Gentlelady yields back. Anyone seeking recognition to speak on the amendment? The gentlelady from Tennessee, recognized for 5 minutes.
Thank you, Mr. Chairman. I want to associate myself with the remarks of Representative Dingle and thank her for her work to ensure that Medicare's home infusion coverage is meeting the needs of America's seniors. I was proud to join Representative Dingle and Buchanan and Sewell in introducing the Preserving Patient Access to Home Infusion Act. The bipartisan bill on which her amendment is based is co-sponsored by a number of our colleagues on the subcommittee, and frankly, it baffles me as well that the Medicare system lags so far behind our commercial payers in providing access to this vital service. And as a pharmacist, I've witnessed firsthand the tremendous power of home infusion, and I know what it means for patients and their families when they're able to receive treatments from the comfort of their home. And I look forward to working with my colleague from Michigan to address this important issue. And Ms. Dingle, I have for many years helped patients with home health and IV services, so it's a valuable service. So with that, Mr. Chairman, I yield back.
Gentlelady yields back. I just want to confirm the gentlelady from Michigan withdraws the amendment. Withdraw the amendment. Okay. Gentlelady has withdrawn her amendment. The question now occurs on forward in H.R. 5397 as amended to the full committee. All those in favor say aye. All those opposed say no. The ayes have it. The bill is agreed to. The chair calls up H.R. I'll correct myself, H.R. 6366, and asks the clerk to report.
H.R. 6366, a bill to amend Title 18 of the Social
Without
Security
objection, the
Act.
first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek recognition on the bill? Gentleman from North Carolina is recognized for 5 minutes.
Thank you, Mr. Chairman. H.R. 6366 provides a one-year delay in the up to 15% cut scheduled to hit laboratories in January. I'm glad to see this going through regular order, and I was glad to see it prioritized in the continuing resolution that passed the House yesterday. Without the delay in the phase-in of clinical lab payment adjustments originated in the Protect Access to Medicare Act, or PAMA, investment in research to improve care for diseases and health conditions will be hindered, and infrastructure and capacity required to meet the country's healthcare needs will suffer, especially in rural areas like my part of North Carolina. These cuts are a flawed implementation of PAMA, which excluded a large percentage of the labs that provide critical services across the country. These cuts also affect some of the most routine laboratory tests, including those for heart disease, diabetes, cancer, and other chronic conditions. A delay in PAMA cuts and reporting is an important short-term fix until we can enact the Savings Access to Laboratory Services Act, or SALSA, which I championed along with Representatives Fitzpatrick, Kuster, Bilirakis, Peters, Bouchon, Crenshaw, and many of my colleagues on this subcommittee. SALSA would address the long-term challenges of the flawed implementation of the PAMA that I mentioned. SALSA is bipartisan. It is bicameral, common-sense legislation to remedy unintended payment cuts to labs providing critical diagnostic services that offer early disease detection and diagnosis, informing tailored treatment, prevention, and care. The U.S. District Court of Appeals in the D.C. Circuit, over 70 patients and provider stakeholders, and almost a dozen members of this subcommittee agree that the failed implementation of PAMA must be remedied. While I look forward to continued work on a long-term solution for labs, I urge my colleagues to join me in support of a one-year PAMA delay, providing critical relief for the most immediate cuts and working on my SALSA bill becoming law. Thank you, Mr. Chairman. I yield back.
Gentleman yields back. Anyone else seeking discussion on the bill? Seeing none, are there any bipartisan amendments? Seeing none, are there any amendments to the bill? Seeing none, the question now occurs on forward in H.R. 6366 to the full committee. All those in favor will say aye. Aye. All those opposed, no. The ayes have it, and the bill is agreed to. The chair calls up H.R. 6369 and asks the clerk to report.
H.R. 6369, a bill to amend Title 18 of the Social Security Act to extend...
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek recognition on the bill? Dr. Dunn from Florida, recognized for 5 minutes to speak on the bill.
Thank you very much, Mr. Chairman. I move to strike the last word and speak in favor of the bill. I appreciate my colleague, Congresswoman Schreier, for working with me on this bill. It is unfortunate that year after year we have to pursue stopgap policies to ward off a variety of unsustainable payment cuts. MACRA was not perfect. In fact, I believe it's in need of reform. The alternative payment model framework is not perfect either, but it is important to maintain the incentive to participate while working to improve the efficiency of the individual alternative payment models. There have been some real success stories in this space. I know docs who are committed to participation in order to deliver higher quality care for their Medicare patients. An expiration of the bonus will compromise our commitment to moving towards value-based care. And fee-for-service care is outdated. It leads to a lack of care coordination and ultimately worse outcomes for the patients. Congress must extend the bonus and work to ensure that APMs are available to a wide array of physicians, including surgical specialists who see fee schedule cuts year after year. I urge my colleagues to support this amendment, and I yield back.
The gentleman yields back. Does anyone seek further discussion on the bill? Dr. Schreier from Washington, you're recognized for 5 minutes to discuss the bill.
Thank you, Mr. Chairman. I'd like to speak in favor of the bill and would like to thank Mr. Dunn for working together on this bill. I also want to thank you, Mr. Chairman, and thank the ranking member for including this bill in our markup today. The transition to value-based care models is so important for improving the quality of care and health outcomes for patients and for reducing Medicare costs. My bill, which I was so proud to introduce with Representative Dunn, will help providers adopt and maintain this model. It will extend incentive payments to providers working in advanced alternative payment models, or APMs, and this helps those providers transition and remain in a model of care that focuses on patient health outcomes. Without further congressional action, these incentives would expire at the end of the year. My bill with Mr. Dunn would extend those payments at their current revenue threshold and rate for 1 year. I look forward to continuing to work with committee leadership on long-term solutions to improve our transition to value-based care. I encourage my colleagues to support this legislation, and I yield back. Thank you, Mr. Chairman.
Thank you. The gentlelady yields back. Is there any further discussion on the bill? Are there any bipartisan amendments to the bill? Are there any other amendments to the bill? Seeing none, the question now occurs on forward in H.R. 6369 to the full committee. All those in favor say aye. All those opposed, no. The ayes have it. The bill is agreed to. So you skip 555 and go to... The chair calls up H.R. 6371 and asks the clerk to report.
H.R. 6371, a bill to provide for certain adjustments to the physician fees.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek recognition on the bill? Dr. Burgess from Texas, you're recognized for 5 minutes to speak on the bill.
Thank you, Mr. Chairman. This committee spent a considerable amount of time, almost 10 years ago, repealing the sustainable growth rate formula through the enactment of the Medicare Access and CHIP Reauthorization Act in 2015. Passing MACRA was a major milestone that was supported by over 800 healthcare organizations. As I've said before, it's important to note that we were solving the problems of the time. And then our shared goal was to help doctors, Medicare providers, and their patients be relieved from the constant threat of reimbursement cuts. Today, we are still facing the same issues of unsustainable cuts for our doctors, and the goal remains the same. So I, along with the co-chairs of the Doctors Caucus, Dr. Winstrup and Dr. Murphy, along with Congressman Kelly on this committee, have introduced H.R. 6371 the Provider Reimbursement Stability Act of 2023. The mechanism of budget neutrality in part contributes to the across-the-board cuts that affect independent physician practices and threaten access to care. I mentioned at our last hearing that this would be the first time that the Energy and Commerce Committee is considering a positive legislative change to budget neutrality. I believe this bill is a step in the right direction to encourage flexibility and accuracy in the Center for Medicare and Medicaid Services determination of the conversion factor, while also promoting stability to mitigate the continuous and seemingly arbitrary cuts. Once again, I want to thank Congressman Kelly for joining us in this effort. We've worked together on many projects, and I'm looking forward to continuing that bipartisanship. Additionally, we'd like to continue to work across the aisle on this bill and welcome additional thoughts and feedback. I've worked with many members in this room on the payment policy for a number of years, and I hope we can bring others on board and commit to working together for America's physicians. And Mr. Chairman, I'll yield back.
Gentleman yields back. Does anyone seek recognition on the bill?
Well, Mr. Chairman, I'd like to ask unanimous consent to insert into the record a letter from the American Osteopathic Association, as well as a letter from provider groups requesting activity on the physician reimbursement.
Yep. Without objection, so ordered. Are there any bipartisan amendments to the bill? Are there any amendments to the bill? For what purpose does the gentleman from Florida seek recognition? The clerk will report.
Amendment to H.R. 6371, offered by Mr. Bilirakis of Florida. Add at the end the following new section. Section 6, increasing the non...
Without objection, the reading of the amendment is dispensed with, and the gentleman is recognized for 5 minutes in support of his amendment.
Thank you, Mr. Chairman. I appreciate it very much. I first want to say I'm fully supportive of the underlying bill, H.R. 6371, which will help provide additional stability for providers under the Medicare fee schedule. This bill will accomplish this by raising the budget neutrality threshold, requiring CMS to continue to update the direct cost relative value units and adjust pricing and limiting the damage of the conversion factor each year. I want to thank my good friend, Dr. Burgess. We're going to miss you, Doctor. But I know we have a few more months left. My bipartisan amendment, which I do plan to withdraw, Mr. Chairman, would insert a new section with the contents of my bipartisan bill, H.R. 3671, the Providing Relief and Stability for Medicare Patients Act, which was noticed in our last subcommittee legislative hearing in October. Of course, I'm disappointed, but I know there's another day there that we were unable to get it on the agenda to mark it up and move forward here today. H.R. 3671, which I lead with my good friend, Representative Cardenas, would mitigate payment cuts to specialty services provided in community, office-based physician practice settings. These non-facility settings help preserve patient access to care and avoid further consolidation in the Medicare program. Office-based specialty care is a critical service outside of the hospital setting. It is also less costly for Medicare and for patients than when such care is provided in more expensive hospital settings. And I mean, it's a win-win for everyone, and I hope we get this done. However, in its 2022 physician fee schedule, CMS finalized an update to its clinical labor policy, and due to budget neutrality constraints, led to significant Medicare cuts for office-based specialists, such as radiation oncologists, vascular surgeons, nephrologists, urologists, and many others. These adjustments in clinical labor costs meant some providers faced over 20% cuts in reimbursement. That's unsustainable, resulting in some physicians discontinuing their services. Very unfortunate to the patients, leaving the field through retirement or consolidating their practices to large systems or private equity interests. Patients are ultimately hurt by these effects due to lack of access to specialty care services in their communities and worse health disparities for rural and underserved areas. And I represent plenty of rural areas in my new district, Mr. Chairman. My bill would provide 2 years of targeted relief for specialty care providers who are most adversely impacted by this policy, starting in 2024 and continuing through 2025. Unfortunately, if we don't act soon, the next round of cuts will lead to more consolidation, and I fear worse outcomes for patients who will pay more and wait longer for their care. We should be doing all we can to prevent this in our healthcare system. I understand that the costs associated with our bill may need to be scaled back, and I am committed to finding a path forward that ensures that the bill is fully offset. This includes potential ways to reduce the percentage of practice expense RVUs applied within the bill. In fact, our legislation was designed in a way to ensure these dials can be controlled in a way that is fiscally responsible. I want to thank Representative Cardenas for supporting these efforts with me and co-sponsoring this amendment. And I also want to recognize Dr. Murphy and Representative Davis on the Ways and Means Committee. I also know that Senator Tillis offered the amendment as well on the Senate Finance Committee last week. So, Mr. Chairman and Madam Ranking Member, I ask that you both please commit to working with me and the other co-leads on this bill to advance this policy further and ensure office-based specialists have stability under the Medicare program. These cuts must be mitigated to allow our doctors to continue to provide great care for patients in our community. So, I can't emphasize this enough. I've talked to many, many doctors, and this needs to get done. So we really would appreciate your consideration, and thank you for working with us. And I'll yield back, and I will withdraw unless there's another speaker.
The gentleman yields back.
Yes.
Is there any further discussion? Mr. Cardenas, you recognize 5 minutes.
Strike the last word. I would like to thank my colleague, Congressman Bilirakis, for bringing forth this amendment, which I believe will be hugely consequential for access to care in community settings. If we are serious about ensuring greater accessibility to healthcare services, we have to address the systematic under-reimbursement for care provided in office-based settings. Office-based specialty care is often a lifeline for patients with a range of conditions, including those with cancer and end-stage renal disease, peripheral artery disease, and others. All of these conditions pose a major risk to constituents in my district, and what is more challenging is that these office settings are facing potential closures or consolidation into larger systems because of cuts. My concern is that closures and consolidation reduce options, creating unnecessary barriers for people seeking needed care. The local clinics will close and patients' access will suffer if this goes unaddressed. I hope that my colleagues agree to work on this legislation and to land on a path forward that supports access to community care. We stand ready to collaborate on this, many of us do. Lastly, before I conclude, I also want to mention that I'm grateful for some of the other amendments being proposed today, which look to fix some of the structural concerns with physician reimbursement. I hope to continue to engage on these issues as we go forward. Failing to do so will contribute to already shocking rates of physician shortages and reduces access to care for patients. And with that, Mr. Chairman, I yield back.
Gentleman yields back. Does the gentleman from Florida seek recognition?
Yes, thank you, Mr. Chairman, and I know you'll work with me on this particular bill, so I'll withdraw the amendment. Thank you.
Gentleman withdraws his amendment. I will recognize myself now to offer an amendment. I have an amendment at the desk. Bouchon 037, clerk will report the amendment.
Amendment to H.R. 6371, offered by Mr. Bouchon of Indiana. Add at the end the following new section. Section 6, updating the single...
Without objection, the reading of the amendment is dispensed with, and I recognize myself for 5 minutes in support of my amendment. I'm grateful that by moving H.R. 6371, the committee is demonstrating an interest in helping to correct Medicare provider reimbursement. I'm offering an amendment which ultimately I intend to withdraw to further highlight this critical issue. I want to thank my colleagues, Representatives Custer, Miller Meeks, and Dunn for joining as amendment co-sponsors. I do have a chart I'd like to show, and I hope everyone would focus on this, and you will see physician reimbursement on the bottom there as reimbursement for outpatient hospitals, skilled nursing facilities, and inpatient hospital has risen along with consumer price increases, and then you can recognize the MEI, the practice cost inflation graph there, and you see where physician reimbursement has gone. For those of you who haven't seen it before, this chart shows why I'm so passionate about working on Medicare physician fee schedule issues. As you can see, in the last 20 years, consumer prices in healthcare have risen more than 70%. And the Medicare Economic Index, which is determined by HHS and intended to reflect the physician practice operating costs, has risen between 40 and 50%. Reimbursement for hospitals and skilled nursing facilities, for the most part, keeps up with these increases, but physician reimbursement is up less than 10%. How can we say we support market competition while sustaining this uneven playing field? How can we say that we want less consolidation when we're basically pushing physician practices to be employed by large hospital systems? I firmly believe that there is already plenty of money in the healthcare system, and it's circulating around in our system, but the dollars, in my view, are sorely misplaced. To raise awareness of this issue and propose a simple solution that would avoid annual payment cuts to providers under the Medicare physician fee schedule, I joined with my colleagues, Dr. Ruiz, Dr. Miller Meeks, and Dr. Barra to introduce H.R. 2474 earlier this year. This legislation would establish an inflationary update for the physician fee schedule similar to what hospitals receive. I continue to believe it is the best way to ensure sustainable, reliable reimbursement for physicians, thereby maintaining access to care for patients. The Provider Reimbursement Stability Act also shows some promise in addressing this problem, and thank you, Dr. Burgess and others for introducing it. I'm happy to be a co-sponsor of that legislation and look forward to continuing to work on the legislation with my colleagues to make sure it will function in a way that helps doctors and patients. My amendment doesn't alter the underlying text of the bill. Instead, it adds a section giving providers 1 year of MEI-based reimbursement adjustment. Because H.R. 6371 wouldn't take effect immediately, Congress and this committee will need to determine how to help providers weather the approximate 4% pay cuts they're facing come January 1st. As we continue to discuss this before bringing to the full committee, I urge my colleagues to consider the benefits of using MEI to adjust physician payments. With that, I yield. Are there any other members wishing to seek recognition on the Democrat side? Seeing none on the Republican side, I recognize Dr. Dunn for 5 minutes.
Thank you, Mr. Chairman. I move to strike the last word and speak in favor of the amendment.
Recognized.
Yes. I, too, appreciate the framework outlined by the Provider Reimbursement Stability Act and look forward to working with my colleagues to enact holistic reform to the physician fee schedule. I do believe that the amendment authored by my friend Dr. Bouchon is well worth considering in this conversation. Consider the Medicare Economic Index when updating physician pay rates just makes sense. Physician offices are virtually only businesses that cannot increase prices when the cost of their inputs increase. The cost of running a medical practice has risen significantly, and the physician fee schedule has simultaneously gone down. I look forward to continuing this conversation and working with my colleagues to get Medicare physician payment reform right for a change. With that, Mr. Chairman, I yield back.
Gentleman yields back. Anyone else seek? Dr. Miller Meeks, recognized for 5 minutes.
Thank you very much, Mr. Chair. I move to strike the last word.
Gentlelady is recognized.
Like the chair, Dr. Bouchon, I too am grateful and supportive of Dr. Burgess's H.R. 6371. But I would also like to speak in support of Dr. Bouchon's amendment to update the physician's fee schedule to account for inflation for 1 year. I'm proud to be a sponsor of H.R. 2474, the Strengthening Medicare for Patients and Providers Act, with Dr. Bouchon, Ruiz, and Barra. This critical legislation would add a permanent annual inflationary update to physician payments under Medicare. While operating costs for medical practices have gone up by 47%, physicians' payments have declined 26% from 2001 to 2023, when adjusted for inflation, making it difficult for small, rural, and low-income serving practices to provide care to patients across America. Our bill stabilizes physician payments year to year and seeks to preserve access to care, which has only worsened since the COVID-19 pandemic. While this amendment would take the important first step of applying the MEI update for 1 year, it is still critically important for Congress to continue its work on a permanent fix to the broken Medicare physician fee schedule. I thank my colleagues for this work on this issue and yield back the balance of my time.
Gentlelady yields back. Does anyone else seek recognition on the amendment? Seeing none, at this point, I will withdraw the amendment. Does anyone else have an amendment to the legislation? Recognize Dr. Joyce, 5 minutes.
Mr. Chairman, I have a
Offer an
bipartisan,
amendment.
I have a bipartisan amendment at the desk.
The clerk will report the amendment.
Amendment to H.R. 6371, offered by Mr. Joyce of Pennsylvania. Add at the end the following.
Without objection, the reading of the amendment is dispensed with, and the gentleman is now recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chair. First, I want to state that I am a firm supporter of the underlying bill, H.R. 6371. But this amendment underscores the dire need for additional reforms and immediate relief to the latest cuts to Medicare providers. I would also like to thank my fellow physician, Dr. Schreier, for joining me as a co-sponsor of this bipartisan amendment. As you know, if Congress fails to take action, Medicare providers face a 3.4% cut next year. However, when coupled with the estimated 4.6% increase in medical inflation, the real impact is closer to an 8% cut in 2024. I would like to thank Congressman Burgess for his work on the underlying legislation that we are considering here today, and thank Chair McMorris Rodgers and Chair Guthrie for advancing this important bill today. Raising the threshold for when budget neutrality applies from the 1992 level is a long overdue change. Providing for a look-back mechanism for CMS to revise incorrect estimates in utilization is a welcome reform. The bill will also ensure that there are regular updates to the direct costs when calculating practice expense RVUs and set a limitation on the year-to-year conversion factor variance. This bill is an important step in the right direction, but we must also acknowledge the need for more immediate relief to stop the pending 3.3% cuts this year and make larger structural reforms in this area. From the period of 2001 to today, Medicare physician reimbursement has actually gone down 26% when adjusted for inflation. This simply is not sustainable for physician practices that accept Medicare and has a detrimental impact on beneficiaries losing the access to their preferred physician. This has also led to the consolidation of practices and driving physicians out of rural and underserved areas like my district in Pennsylvania. This amendment would simply provide needed relief for providers for an upcoming year while this committee can continue our important work to reform the program so that we are not caught in this perpetual cycle of stops and stopgap mitigation. Chairman, while I intend to withdraw this amendment, I hope to work with you and my fellow committee members to protect our seniors and providers by finding a way to help prevent these devastating cuts that will go into effect on January 1st, 2024. Thank you, and I yield for any additional speakers.
Gentleman yields back. Recognize Dr. Schreier for 5 minutes to speak on the amendment.
Thank you, Mr. Chairman. I'd like to strike the last word and speak in support of this amendment. First, I just want to say overall how much I appreciate this attention to the physician fee schedule, given the disparities just highlighted by you, Dr. Bouchon, and every physician in this committee is acutely aware of this need, and we hear from our colleagues. I want to thank Mr. Joyce, Dr. Joyce, for his partnership on this amendment. We often work together to offer some immediate help and update the physician reimbursement conversion factor to 4.62% for the reasons he just highlighted. I share his concerns about the impending cuts to the physician fee schedule that will come at the end of this year without further congressional action, that will come at a time when we are seeing high levels of physician retirement and early retirement and resignation. So I want to encourage the committee to work on averting these cuts before the end of the year, in addition to looking at some long-term solutions. Thank you, Dr. Joyce.
Would you yield your time?
I will yield back to you.
Thank you, Dr. Schreier. And I will yield my time to Dr. Miller-Meeks.
Thank you, Dr. Bouchon and Dr. Schreier. Last year,
Okay, never, technically, Dr. Schreier would need to yield to Dr. Miller-Meeks, but that's okay.
I will yield to Dr. Miller-Meeks.
Thank you, Dr. Schreier. As I previously stated, I support the underlying bill, H.R. 6371, but I speak in support of Dr. Joyce's amendment. Last year, Congress passed 2.5% relief for 2023 and 1.25% for 2024. This still leaves doctors facing a final cut of 3.37% for 2024, which includes the 1.25% of relief Congress passed last year. I rise in support of Dr. Joyce's amendment, which would raise the reimbursement by 3.37% to ensure that doctors across the nation who are already facing tremendous challenges maintaining their independent practices are adequately reimbursed. Please remember that when inflation skyrocketed to 9% in the previous year, prices have not come down and are still up over 17%, and the challenges of employing nurses and other staff are acutely felt in physician practices. Consistent and sustainable reimbursement is crucial for patient access to care, especially those in rural areas where access challenges are naturally more severe. Thank you, Dr. Schreier and Dr. Bouchon, for yielding me time, and I yield back the balance of my time.
Generally yields back. I now recognize myself to speak in favor of the amendment. I recognize myself for 5 minutes. I would like to indicate my support for this amendment. If we are unable to enact an MEI-based update for 2024 due to cost and other concerns, this is what we have to do. We have to mitigate this impending cut. This is a great alternative to a more permanent solution in the short run. For many years, I worked with my friend, Representative Baird, to provide end-of-the-year conversion factor adjustments for doctors, along with many other doctors in the Congress, as well as some of my other colleagues. While I sincerely hope this committee can eventually agree on a long-term fix for provider reimbursement, we must also act in the short term to ensure we maintain physicians' willingness to participate in Medicare. Any further cuts to Medicare provider reimbursement will continue to devastate the ability of seniors to access health care providers, particularly in rural and underserved urban areas of our country. I support this amendment, and I yield back my time. Does the gentleman from Pennsylvania intend to withdraw his amendment?
Yes, Mr. Chair, I wish to withdraw the amendment.
The gentleman withdraws the amendment. Any other amendments to the bill? Seeing none, we'll now vote on H.R. 6371. Those in favor say aye. Those opposed say nay. The ayes have it, and the bill is passed and forwarded to the full committee. The chair now calls up H.R. 6364 and asks the clerk to report.
H.R. 6364, bill to amend Title 18 of the Social Security Act to maintain certain telehealth flexibilities relating to the provider privacy under the Medicare program.
Without objection, the first reading of the bill is dispensed with, and the bill will be open to amendment at any point. So ordered. Does anyone seek recognition to speak on the bill? Dr. Dunn, you're recognized for 5 minutes.
Thank you, Mr. Chair. I move to strike the last word.
Gentleman's recognized.
I'd like to speak in support of this bill by Mr. Balderson, and I'm glad to co-lead with him. This bill simply prohibits CMS from ever posting online or making publicly available a doctor's home address when a doctor uses that home address as a distance site from which to conduct telehealth facilities and services. Doctors should not have to choose between their safety, their privacy, and their ability to provide telehealth services from their home. We all know by now the value and convenience of telehealth for both providers and patients alike. As we examine the future of telehealth, We must keep the system nimble and responsive, but also free of fraud, abuse, and risk. We want to allow the doctors to provide telehealth appointments from whichever location they want to or need to, including from their homes when appropriate, without jumping through bureaucratic hoops. At the same time, CMS must have access to the information that they need to track usage and investigate cases of fraud. We appreciate CMS extending for another year the provision that allows providers to list their practice address instead of their home address on their Medicare enrollment. But we must go one step farther. I look forward to working with this committee and with CMS to develop permanent mechanisms on this issue that appropriately balance confidentiality with program integrity guardrails. And I urge all of my colleagues to support this bill. With that, Mr. Chair, I yield back.
Gentleman yields back. Does anyone else seek recognition to speak on the bill? Seeing none, are there any bipartisan amendments to the bill? Seeing none, are there any other amendments to the bill? Seeing none, I got to get to the right page. Question now occurs on forwarding H.R. 6364 to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes have it. The bill is agreed to and forwarded to the full committee. Chair now calls up H.R. 1352 and asks the clerk to report.
H.R. 1352, a bill to require the Secretary of Health and Human Services to establish a demonstration project to increase access to biosimilar biological products under the Medicare program.
Without objection, the first reading of the bill is dispensed with, and the bill will be open to amendment at any point. So ordered. Does anyone seek recognition on the bill? Gentleman is recognized for 5 minutes in support of his bill.
Thank you, Mr. Chairman. When I'm back home in North Carolina, I consistently hear from seniors about the high out-of-pocket costs of their prescription drugs. As a sponsor of H.R. 1352, the Increasing Access to Biosimilars Act, I appreciate my colleagues. I thank you for joining me in this effort to lower costs of prescription drugs for seniors through common sense solutions. This bill creates a new voluntary pilot program to evaluate the benefits of providing additional shared savings payments to providers of biosimilars under Medicare. Through a shared savings demonstration, providers will be encouraged to prescribe lower-cost biosimilars medicines, and savings will be guaranteed to the federal government. Biosimilar medicines hold enormous promise to significantly increase patient access to advanced treatments and reduce the cost of prescription drugs. And this bill encourages adoption of biosimilars in Medicare. With the Research Triangle Park right next door to my district, our state thrives on innovation. This sort of solution encourages greater biosimilar adoption and use in the United States and could save the healthcare system $133 billion by 2025 if they're fully available and accessible to patients who need them. A bill that saves money and increases patient access and lowers patient costs should be a no-brainer. I look forward to seeing this bill become law and thank the chairman for bringing it through the committee today. With that, Mr. Chairman, I yield back.
Gentleman yields back. Does anyone else seek recognize the ranking member of the full committee? Mr. Pallone, 5 minutes.
Thank you, Mr. Chairman. Incentivizing the development and utilization of biosimilars is critical to driving down drug prices and reducing the high costs of specialty medications, particularly in the Medicare Part B program. So I'm pleased there is bipartisan support for ensuring we have a robust biosimilar marketplace, and that's why we passed into law an important policy that created a 5-year temporary payment increase for qualifying biosimilars in Medicare Part B, in which the Medicare program will pay the average sales price for a biosimilar plus 8% of the reference biological product's average sales price when the biosimilar is separately payable in physicians' offices. Now, by increasing the ASP add-on, physicians are more incentivized to prescribe the biosimilar over the reference biologic, driving down costs to the Medicare program and increasing access to lower-cost drugs. However, instead of extending this common sense policy and building on the work underway, H.R. 1352 establishes a new nationwide demonstration project in the hopes of increasing access to biosimilars under Medicare Part B. But it would be years before the completion and final evaluation of the demonstration project, while beneficiaries in the Medicare program need greater access to biosimilars now. So I believe that we should be considering Representative Cardenas' legislation instead, and that's the Extending Biosimilar Eligibility Act. That bill would extend the temporary payment increase of ASP plus 8% for biosimilar products in Part B for an additional 5 years. And that is a common-sense solution that achieves the bipartisan goal of growing and incentivizing a strong biosimilar market. And with that, Mr. Chairman, I yield back.
Gentleman yields back. Anyone else seeking recognition on the bill? Yes, Mr. Cardenas, recognized for 5 minutes to speak on the bill.
Thank you very much, Mr. Chairman. I move to strike the last word. Thank you. During my tenure in Congress, I've long supported access to biosimilars that will provide much-needed relief to patients trying to afford their prescriptions. These products have incredible potential to both provide lower-cost options to patients and introduce more competition into the market, ultimately lowering the price of the higher-cost reference products. In the past, I have led efforts to create new incentive programs to improve uptake of biosimilars. I'm glad that my colleague on the other side of the aisle shares this aim, even if it means he's willing to go to such great lengths to lead on the bill. But I also want to add that I think we could be doing much more. Because of this, I have introduced legislation to give even more biosimilars the opportunity to benefit from increased Medicare Part B payments through the ASP Plus 8 program. Specifically, my bill would extend the window of eligibility for a biosimilar to qualify for 5 years worth of pay increases at the average sales price of 8%, plus 8% level. By folding in more products to the program, we can grow the biosimilar market and ensure more patients are benefiting from these lower cost options. If we share this priority of improving access to biosimilars and incentivizing growth in the market, we should look at a fuller suite of policy options. I hope that I can work with my Republican colleagues to come to an agreement on this type of policy. Let's not forget what this is all about, lowering drug costs for hardworking families and making impossible decisions between affording medications and other necessities a thing of the past. With that, I thank you and I yield back.
Gentleman yields back. Anyone else seeking recognition? Seeing none. Any bipartisan amendments to the bill? Seeing none. Are there any amendments to the bill? Seeing none. The question now occurs on forwarding H.R. 1352 to the full committee. All those in favor say aye. Aye. All those opposed say no. The ayes have it, and the bill is agreed to and forwarded to the full committee. Without objection, staff is authorized to make technical and conforming changes to the legislation approved by the subcommittee today. So ordered. Without objection, the subcommittee stands adjourned.
Happy Thanksgiving, everyone.